ऐसे On this occasion of technology update on the Department of Pediatrics and IIT City Branch Jammu, and I welcome you in this city of temple. And now I introduce today's first speaker. Some flag Gujarat Center for Blood Transfusion, Hyderabad, formerly Director of Indira Gandhi Institute of Child Health, Kabul, Afghanistan, Honorary Medical Advisor to Armed Forces Medical Services, then Medical Advisor, Federation of Indian Thalassemia and National Thalassemia Welfare Society, and has received multiple fellowships, Indian Society of Hematology and Hospital Medicine, Fellowship and Indian Academy. Received multiple awards and is editor of Indian Journal of Pediatrics, Chief Editor, National Thalassemia Bulletin, and editorial member of Indian Journal of Hematology and Blood Transfusion, editorial member of Indian Journal of Medical and Pediatric Oncology. And now I request talk for today.
It is always a pleasure to visit Jammu, and I have been coming, I don't know, for the last 15, 20 years plus, and because the thalassemia is close to my heart, and that is how I have been visiting. And whenever I come, Dr. Gigira has been always been kind and wants me to share some of our experiences. Taking to the today's, everybody always feels speak on the ABC of the CBC. You see, when I was an undergraduate, or even till after my post-graduation and so on, physicians and surgeons used to write SP, GMC, and many times they used to write only SP and TLC. The platelets, because most of the labs were not doing it. There has been a big revolution in this part, and today, the part is that the person who reads it should know how to interpret the data and how to look at it. What we say, the eye sees what mind knows, and if our mind doesn't know what these lovely charts, these curves are, and then person is, these curves stand no meaning at all. And I think what we are talking is, we talk of the spheres, and we have various necessary indices when we talk. Of course, your first parameter is HV, and you do the RBC count. Based upon these two parameters, a lot of calculations are made. What is the mean cell volume, mean cell hemoglobin level, MCH level, MCSC, what is the red cell distribution width? All these parameters make a lot of sense and give you what could be the possible underlying diagnosis. Similarly, when it comes to the platelets, what is the mean platelet volume? And I will talk to you about the IPM value, and so which will give us even a guide to the clinician whether to treat or not to treat, and I'll talk at that stage. Now, the person who was literally behind was a builder. He was an electrical engineer. He said, what you people are doing? Let it work out and give you very. And he came with a counter which takes a few micrometers of blood and gives you at least today's the latest parameter. He got 30 odd parameters from that. And the advantages of it is based upon what are the principles. It is as the thing is passing, it is through the principle of impedance or light scatter. Whether it is producing the based upon the cell size, it is producing these waves, and the size and the shapes which come. And so it is the number of pulses which indicate the cell count. The amplitude which is there is the proportion of the red cell, the bigger cell, smaller cell, and the beam. That gets calculated based upon the amplitude what you get on that. And so based upon the principle of resistance, the two counters which work are Beckman counter and the 6-Mintz counter. And then there is a light scatter which is based upon the optical and laser pattern. And there are the systems which work with the detectment, wear and edema systems. So there are almost 5 counter systems which are available today, and everyone has different models, 3-part differential, 5-part differential, 7-part differential, depending upon your load, depending upon your facility, what you want to develop. Again, the forward scatter which it produces has a measure of the cell size, and the side scatter gives you a measure of cell complexity, its granularity. It's all these parameters come on these systems. Now, when you look at it, that is what it is talking. These are the histograms which gives a These are the histograms which I have shown on the outside, and it gives you, for example, the bottom, RBC, see these curves, and the platelet count. On the top one is the differentials, and the platelet count. So all these count, what type of subpopulation it is, and their average size in relation to the rest of the size of the cells, and their relative numbers. So that is what it gives you the parameters. Now, what are the advantages? So, when we were doing by the previous method, the technician in a day at the post was able to do over 8-hour job in 50 to 100 samples depending on. But now here, it does hundreds of samples in hours. Every tube perform multiple tests at a single time. So you run the tube, it means RBC count, SP platelet, all these parameters in a 2-second test. A printout comes out for you with the analysis. So it is a marked reduction in the labor. And the data is very accurate. Because when the technicians were doing individual differences and so on, used to make a lot of differences. But here we have the absolute calculated stuff. The other is, when they come, they give you flagging. Now, what is the advantage of the flagging? The counter says, if you get all that curve and paper, no flagging means everything is perfectly normal and Dr. Paul doesn't need to look at it. He will just sign it and say normocytic, normochromatic. Ultimately, everything is supposed to be. But then there are areas where it will get flagging. Which means anything which is beyond the parameter, either on the lower side or on the upper side, it gets a flag and it wants Dr. Paul to look at the smear that what is the problem lying under. So that is what the purpose of flagging. And then even it will tell what are the immature cells. The red cells, again, why this cannot be separated by red cells. After what is the principal size of a cell? We know anything between 3 to 5 micron is a platelet, 5 to 10 is a RBC, and WBC is the granular and infiltrator cells. So now, any cell in a hemolytic anemia, small red cell, the counter may count as a platelet. If a patient who is IBD and is having big platelets, giant platelets, or so on, it will get counted as RBCs. So now you see these are the differences which come. For RBCs, it will not make a difference. Millions few cells, hundreds come, thousands come in the platelet, RBC count doesn't get affected. But on the platelet side, if 20% are ahead of platelets, the platelet count of 1 lakh will reduce to 80,000, 20%. So that makes a difference, and that is what the flagging comes in the look. And the histogram will say the curve is going like this flat curve. It doesn't comment on the direction. I'm trying to convey you, man behind the machine is more important than the machine itself. Whatever goes on, the pathopathologist sitting is the most important to differentiate and advise. So don't go on the counter. These are counter is showing this patient. Their opinion is far better than the person's far better. And then it is at times erroneously decrease of the higher cells, which I told you the example of the RBCs or the platelets because they are frequent joint platelet. If you get a platelet aggregation, it will reduce platelet count will be low, whereas patient has a normal platelet. So this is what are the disadvantages, and these counters cannot be done. The other is these are expensive than the manual, but the time factor is now, what is said is we have a 3-part, 5-part, and a 7-part differentiation. In the 3-part, what you were getting was the granulocyte, lymphocyte, and big cells. Whereas in the 5-part differential, you get the neutrophils, eosinophils, basophils, lymphocyte, monocyte, which you are getting a differential into the 5-part. In the 7-part, what comes is what are the nucleated RBCs coming in that, what are the abnormal cells into that, what are the atypical cells into that, and what are the immature cells, that is immature platelet cells or immature RBCs. So all that will come, and that gives you the one. Actually, as you are advancing, the from 3-part, 5-part, 7, the test becomes more expensive. So you can't get better data with a lesser cost. So you have to think. But now this is what I was talking. Now look at the RBC. This is the curve which you get from where it starts. The pointer is not showing there anyway. So the peak cell, that is, if there is shifting, I'll show you in the subsequent one. And when we do the red cell, it talks of hemoglobin, RBC count, NCP, MCA, red cell distribution bit, which I will show you subsequently, not in this one. And that is, and the relative frequency of cells comes on the x-axis, and the y-axis comes the number of cells which will build. Now, this is what I was talking to earlier. Now, it is measured at two levels: standard deviation, that is at 80%, the lower one, and the CV at 50%, and that gives you, which means if RDWD is the distribution width is broader, which means the cells are many are smaller, some are bigger, and it gives you the mean of it, and then we will talk which are the conditions where it is increased, you will know it. And it gives you population size. If a large RDW says that a wide variation in the RBC and parameters, and younger cells are and larger, which means their reticulocyte count, which is their older and elderly cells are smaller ones than some cells. And so this is the, then we come on to the reticulocyte count, which is a normal you have reticulocyte count. You need to correct with the hemoglobin, because if the hemoglobin is low, the bone marrow will more regenerate. Now, let us say hemoglobin of 6 grams, it has a RAT count of 6%. Right? Normal person will say it is not high, whereas actually it is not high, because 6 grams, if I raise to 14 grams, 13, 14 grams, it will fall less than 2%. So that makes it different. And then what it gives you is, beside that, absolute reticulocyte count. So that gives you another additional advantage of doing the counter. And then what are the immature? The purpose of immature is that more cells, bone marrow is very active and is producing more cells, and they are immature and they are coming into the circulation. The immature reticulocyte count, again what I said, bone marrow is regenerating, and if patient with, let us say, aplastic anemia, or is a patient with leukemia who has been treated, and if you find that the immature cells are coming out, it gives an indication to the physician and the pathologist that the marrow is going to regenerate, So don't worry, the things will improve in next week or 2 weeks' time. And then it gives you, even for a patient with a megaloblastic anemia, it may be good, and if your immature reticulocyte cells have increased, means that marrow is responding and your hemoglobin will get corrected much faster. So these are some things which give you, and it gives you time for mobilization. So we have talked on the red cell fragment. Then the differential count. This is based on the impedance or fluorescence flow cytometry, which gives you a cutter punch, and then of course it does the NPO staining, which will tell you on the granulocyte stage whether they are large stage, and then again it will tell us immature cells which are coming into the. Now this is what, when we talk about differential, when you get these curves, you get these type of curves. The second part, this middle part is what density and gives you what are monocytes and the other cells which are coming. Now this is what you get in these programs here. This is the pie part where I have shown you on this, on the BCS technology. The volume is determined by the impedance, conductivity, and on the electromagnetic probe which is shown, and the colors are the ones which you use to identify. And you can use the fluorescent method to give us a more better even differentiation, but basically it depends on these curves, and then the clusters of cells which you are looking at the diagram, which tells us how many are lymphocyte, neutrophil, and so on. This is the immature granulocyte. Now, when you get the immature granulocyte, naturally a patient who has a bacterial infection, acute inflammatory diseases, patient who has gone on a bone marrow transplant and is recovering, or patient who has mitochondrial disorders, diseases, and in many times you get patients who are on steroids. So you know that what is total count is high in some T cells. So these are all the parameters in this area. Now, what this is the scatter hand I was talking to you. Let us talk about it. Now, here is a patient with HP of 10, WBC is high 41,000 top one, and then you have a platelet count of 59,000. So you have the measurement, MCV is now 79, MCV, all these parameters are coming, and there you see the neutrophils is not talking. And if you look at that one counter, the very little small scatter is there, so it gives you the picture, and then it is flag, that is called flagging or starring, and giving an indication that you need to look at what are these abnormal cells which need to be identified. Now this is another one. If you look again, SP is 9.2, WBC is 1 lakh, and the platelet count is 63, and these are the parameters which we show. And this is how that it looks at a person when there is a patient who has a large cell bone, that is the same patient, and the bone line showing 65% loss, which is not 1 lakh. So they are dragging, converted into the smear examination, gives us a clear diagnosis. Now, again, when we are talking, when I talked in a pediatric, Dr. Peter has organized, you are dealing with a pediatric problem. So we ought to know what are the parameters at different ages. These are given in books. I don't think you should know that the child at birth has a hemoglobin of 6. Around 12 to 30 grams. Similarly, the hematocrit, the NCV, in a newborn is 108 in the first month of life, then it comes to go to normal. So don't think a child who is newborn with a high NCV could take over here the people. That is a nonsense one also know. And so are the reticulocyte count also, the newborn baby is higher. And these are the parameters. Even the WBCs are higher. One ought to know the parameters. Now, the spear looking is one thing which is very important. Now, here you find the patient has erythrocytes. On the other side, you find the patient with the target cells. Now, look here at the ear drop cells. And the stomatocytes, look at that one. I put these arrows and taken because monitor is different. And then, Howell-Jolly bodies. Now, these are not Howell-Jolly bodies decomposed DNA material commonly seen in patients with hypofunctioning of spleen. Because normally the spleen should engulf it and one these bodies should not be there. Or a person who has gone under splenectomy. Supposing I go and discuss with the patient, with him, Dr. Bob, he looks at the sphere, looks at the organ, he says, is the patient splenectomized? I say, how did he come to know? Nothing, not that Mata Devi ne bata diya ye ho gaya. So the knowledge that it is a Howell-Jolly body present there, and that will be seen in patient more common in patient with Now, similarly, the basophilic stiffening, what you see here, these are aggregation of ribosome RNA, and most commonly seen in the leg body. The story what I told, I always give, working at age, VVIP used to come, where they go to cardiology ICU. And if, without making good aid, his hemoglobin was 11 grams, and 11 and let us send to the performance. It came to us. We were looking at the smear and we saw this. Then we asked, who is this person and from where he has come? So I don't want to tell that. So we just look for lead poison, looking at these ones. And the cardiologist did the lead level, it was very high. The reason is we know in certain areas the lead level poisoning is high and the levels are high. Now, the toxic granulation. When you see in the neutrophils like this, so you know that the patient is going to have permanent infection, case of burns, or in malignancy, And so you need, and of course, you need to distinguish them from the basic. Similarly, you see these cells and nodal cells. These are sky blue brilliant, and again they are seen in the similar patients with infection, burns, microfluid disorders, and so on. Now, I thought after giving you a bit of this, let's have few cases if the time permits, and whenever you want, we'll stop at that time. Here is a patient with SP of 6.4, TLC 6600, platelets are on the little on the higher side, MCD 57, MCH 20.4, RBC count is low, RDW is very high, 22.4. So what could be the diagnosis? Anybody wants to do? Answer coming. Look here. The RBCs are decreased, RDW is very high, mental index which was calculated was more than 26, the platelet count are increased, and this is a case classical with a higher dose. So what we showed you. On the same parameters, so you don't need to do pseudovirus study paradigm. Now if you come to the other case, 5-year-old boy having a low hemoglobin, counts are normal, the platelets are normal, MCD is low, MCH is low, RBC count, the previous case was high, here it is, RBC count is higher compared with the hemoglobin at 9.4. RDW is normal. So, it is a microcytic hypochromic picture, RBC is increased, RDW normal, mental index is this, and RBC. So, diagnosis have minor. So, all what we advise, get in a HbA to that will give us. And then you can do the hemoglobin electrophoresis, A2 was reached, and patient was alpha beta cells. These are some of the tables which I have given. How? Because the two conditions, iron deficiency is a national problem. Thalassemia is another problem. How one could differentiate, and these are the tables that indicate very clearly, and if you follow this, this is given in books, and I will from the back of and if somebody wants, you can take a picture, and this is one which will tell you very clearly. Otherwise, go and read your pediatric book, at least in 2 editions, my chapter is there, and each table is given there.
Thank you, sir. Thank you for such a lucid and detailed education on the topic. We are already started on time.
Okay. I said to begin with, I put certain cases, 5 cases, to explain the principles of the use of CDC, and whenever you see that, you want right away, absolutely. Now, this is another case. Now, what is your this is another chair first. Okay, we take 1 or 2 cases. I will run to this table. Now, this is 2.5-year-old child living in Pediatrics, has this year FICA, and has a retarded mind. Look here, and that is what we told you, the red poison. And in Pediatrics, because of industrial area, the groundwater is rich in lead. Now, this is, okay, we skip this example, right? We go to space. Thalassemia, we have talked. We will talk on this nucleated red cell drugs. These are the coming cells which shows up increased electrolytic activity, and this can, besides this, they can, besides that the marrow is proliferating, that can also be patients with myelofibrosis, leukemia, storage cells. So you need to keep a critical diagnosis moment to find these nucleated RBCs. We'll go on to remove these cases because of short of time. Pancytopenia case also not. These ones. 7 Now, it basically indicates if it is increased in the regular number of the platelets. And the conditions you see are IPP and PPG, Werner-Suter syndrome, and then of course uncommon genetic disorders. The low platelet volume we see is like Wiskott Eldred syndrome and X-thrombocytopenia. So these are the platelets that you see, and one needs to work out on that. What are the dual parameters in the 7-part definition according to your stock data? Two, immature platelet, immature reticulocyte, immature reticulocyte count, red cell fragments, and reticulocyte hemoglobin. These are the 7-part definition which give us these parameters. Now, immature platelet questions are seen on the flow cytopenia using fluorescent light method. And these are the newly released large platelets. It reflects that the thrombopoiesis is active. And now the advantage of such a patient is that if you here, give you a case demonstration, patient's IPM is 24%. It is increased. So if I get this figure information, so I don't need to give a platelet to such a patient. If we are not bleeding, I know in 24 hours the platelet count is going to jump. See the importance of having such a rather than if one has a platelet count of 10,000, the person will rush to the blood bank, get a heart beat, the speakings again. But if you get this IPS of 24 coming high, you know the patient is not bleeding, tomorrow platelet count will jump. The advantage of this. Now these are the IPA which are decreased in aplastic anemia, leukemia, marrow suppression. They are high in IPP, PDP, DIC, and a patient with a dengue. More important, you get dengue fever and if your IPF is high, don't rush to give a platelet now. It will increase in another 24, 48 hours. Now this is immature platelet fractions, which are again see on this other part. And again you see, when the low platelet count, low IPF means low production. And so you need to transfuse the platelet. If the platelet count is low and high IPF is there, and that is what you don't need to give a platelet transfusion. Then there are large platelets, which you see in various situations. And so to conclude what we say, that this technology has helped us in making an early diagnosis, reduce the load on the technician. They are very efficient, and even it has reduced the load on the hematopathologist. If you get thousands of smears, CDC, if you have to screen for 50 or 100 and the rest, he can pass it on as a normal. And based upon these, either automated cell counter, they are screening devices. And in which the inventory still remains important. And the hematopathologist has the last word. And the last word on my part. Thank you very much for being with me. And
thank you, sir. Thank you for very detailed and insightful talk on interpretation of CDC reports. I would say we have numbers in a hospital, in every city hospital. But it's very important. I always tell my PGs, go back to the interpretation, check every parameter, because every report is a new learning. Yeah. So it's not only signing on the reports that you don't have to see the slide list. Every report has a detailed interpretation which you should try to do. And sir, your talk was really, very insightful and eye-opening and learning and also the new students were joining. And it's always so good to listen to you. Thank you, sir.
oh, thank you very much. No, the question basically always right. I always say, I can see only what mind looks. Which is even unethical, even unethical. If you see a back to the many times you used to say, when he walks in for examination, stopping many times to take a dive because he teaches a new thing. Because on his walks for stopping, he ought to know. And my boss a couple of times called me. I was a postgraduate. What is your diagnosis? And you start looking at just everything. You make a correct diagnosis in right. And if you say wrong diet, he says you will have to be the next year again. So that is what they do.
But the main side effect what I see in this, that the BTs and residents, this is only two sides which causes this. They are not used to screen with the result gets weak with screening the entire life. And then the experience about the mind starts working. Seeing PPF and at the same time what is happening in the bone marrow, they cannot be overlooked. So I think the biggest problem in this is that these analyzers cannot pick up thalassemia and myelofibrosis. They need to be kept because we have silent carriers. Then there are other factors also. But unless and until you screen this iron, and that's the morphology. You see, iron deficiency anyway is rampant. But thalassemia can also be there. But what would be the one single finding in the RBC which will rule out the possibility of iron deficiency? Now, this kind of an experience which is must for a pathologist is like that might be.
See, the question is, you become expert based upon your experience, based upon your interpretation, and over the year you learn. I'm still a student and I learn. Today, I learn more from the students and I more learn from lectures, the questions which they are asked. If I cannot answer, then I go and try to find out what could be the answer. This is why you are always learning. You see, the medicine is a continuous flow. Let us say patient with iron deficiency anemia has been put on iron therapy. Now the cell counter doesn't know. And he is not going to interpret. He will say high reticulocyte count. The marrow is hyperactive. You start looking at protein. Not a take any appearance because iron deficiency put on this. Now, you give a patient thalassemia, give a blood transfusion, how the cell counter is going to tell you what is the impact on it? But the question is not this, then you need to do molecular diagnosis. Even you and I cannot differentiate in that situation because you run an XPLC, A2 will not come diagnosed. F is low. You know, F is low. F is low, so you cannot make a diagnosis of that. Child is, and I have done when we were students, these were not there. We used to keep a patient home for transfer for 6 months, and still SPF did not work. So now, of course, we don't need. Ask for a molecular study, and you get the report and this, and then you identify the information. So the what question basically is what your technology has facilitated and helping us to make a diagnosis faster and more accurate, and they are helping us. Today you run on the iron study, the experience, it gives you the 2 minutes the report comes. And earlier when I was a student, we were running the column chromatography, it used to run to days to get a report. Anyway, I think comments are very Thank you.
Thank you for presenting your extensive clinical knowledge with such clarity and depth. Now I request our respected chairpersons to kindly educate our speaker, Dr. V.P. Chaudhary, as a token of appreciation and gratitude from the organizing committee. With that, we come Department of Pathology, GMC, Jammu. Dr. Mohammed Razak, Professor, Department of Pediatrics, GMC, Jammu. Dr. Ravi Prihar, Associate Professor, Department of Pediatrics, GMC, Jammu. And Dr. N.K. Prakash, Pediatrics. Thank you, everyone. Moving forward, we would like to invite our next chairperson for this session on metaphysics and diagnosis and challenges. Dr. Sandeep Dogra, Professor and Head Department of Microbiology, GMC, Jammu. Dr. Vishal Tandon, Professor, Department of Pharmacology, GMC, Jammu. Dr. Salim Nasri, Professor, Assistant Professor and Head Department of Pediatrics, Dr. Kaushal Sharma, Assistant Professor, Department of Pediatrics, GMC, Jammu. Dr. Kavinder Kumar, Assistant Professor, Department of Zoology and Human Genetics, Jammu University. I am hand over the mic to the chairpersons to please invite the moderator for the session.
May I request the moderator for this session, please.
Good morning. And Dr. V.P. Chaudhary, Dr. Sanjeev Dingaji, esteemed faculty members, ladies and gentlemen, most of you are my students. And when I say my students are in front of me in these present positions, I feel that I have not wasted my time in GMC. And Dr. Joe, I'm thankful to Dr. Sanjeev Indra. यार एक शेर आपके नाम कौन था इस जहां में जो हमें कौन था इस जहां में जो हमें खरीदा हम तो बिक गए गुरु से खरीदा Now I call most of they are my students and some batchmates of my son. So today I am not a teacher, I am a fatherly figure. And call the panelists who are the faculty from Department of Pediatrics, Dr. Anmodan Gupta. Dr. Anmodan. Dr. Sanjay Sharma, और ये भी Dr. Pooja, diagnosis. Vidyamani often asking, okay, Dr. Permission. Now my talk is simple also, but I can thalassemia, beta thalassemia, its diagnosis and challenges. It is very straightforward when the situations are ideal. Very straightforward. But if the situations are not favorable, the same straightforward diagnosis becomes possible. And there are other challenges also, which we will discuss. Now, thalassemia, it was in 1925, Thomas Benton Cooley, we find the first description of thalassemia in medical literature. That was in 1925. Although he gave it a different name, which was not acceptable. Probably thalassemia term, which was coined later, people thought that there should be some Mediterranean touch to that term. And exactly after 100 years, now it is 2025, I have the honor of discussing the thalassemia with esteemed panelists and a great audience like you. Definitely, I can't be a Benton Cooley. You see, thalassemia, if I see, it's not a single entity. It's not a single entity disease. It is a syndrome because it's a collection of related genetic disorders with common underlying cause, but with a great and wide variation in the clinical manifestation. So, defining thalassemia, you have a number of ways, depending upon how you look at it and how you have understood the disease. Now, starting with this, yes, Dr. Anmodan, yes, please. How would you like to define thalassemia and what are the consequences with it that can lead to associated clinical syndromes?
Question from the question. Basically, thalassemia it is a genetic inherited disorder.
My
Abnormality which causes structural difference in the heme protein and the globin protein. So globin basically some genes of polypeptide genes and alteration in those genes. This leads to a structural deformity of the hemoglobin and leading to consequences like anemia, which is the first and foremost consequences we see, and then followed by the other effects like of hemolysis and extramedullary metabosis. All these things can lead to a conundrum of symptoms which can have a different clinical syndromes right from a little adult, right from a fatigue to a symptom may require or require a number of transfusions to keep
Yes. So coined the name thalassemia. Thalassa is C, that is a green, and anemia is the later in blood. And it was proved later what Thomas Cooley had described the 8 cases, those were nothing but thalassemia major. Now, coming to the definition, I have, my mind is like this. It is a heterogeneous group of inherited anemias. It is passed through the family and via genes. And inherited anemias are characterized by defects in the synthesis. So basically, there is a hemoglobin production which is either deficient or is not forming at all. So the resultant is anemia, which is microcycle and hyperforming. At the same time, there is an accumulation of imbalance. These beta chains, these imbalanced alpha chains. Because alpha chains, they get precipitated. You must always understand the ratio of alpha and beta chains in the erythroid precursor to be each one is to 1. Any free chain means toxic to the cell. So they become precipitated, form inclusions, get attached to the membrane damage, and undergo apoptosis. And vast majority of erythroid precursors, at least in beta thalassemia major, are destroyed within the marrow. 85% of erythroid precursors are destroyed like this, and most of the destruction occurs at the level of intermediate erythroblasts. There are about 15% of cells which gain entry into the circulation, but they are trapped in the spleen and they are engulfed by the macrophage. So, element of ineffective erythropoiesis is profound erythroid hyperplasia. There is widening of medullary cavity. At the same time, there is hemorrhagic anemia as well, but that is only about 15%. So therefore, these are the basic underlying mechanisms which have resulted in number of things. You see, ineffective erythropoiesis, erythroid hyperplasia, widening of marrow cavity, and extra medullary hematopoiesis is there. Then erythroid masses can be fed on other organs. At the same time, the iron absorption from the gut. Remember, any condition which results into ineffective erythropoiesis will have an effect on iron absorption. So all these situations will ultimately later on develop into, because palliative treatment is the regular blood transfusion, so iron overload and other issues. Dr. Sankar, what are basically, you see, clinical manifestation briefly mentioned, but what are the contributing factors for clinical manifestation? Suppose there are two symptoms, and you have an identical thalassemia mutation. Is it always necessary that both of them will have this similar clinical features, or they can differ? Please.
Local.
For the part of clinical presentation for a case of thalassemia major, we all know that usually by the age of 6 months the child presents as a case of pallor. The child is lethargic, has history of poor feeding, the child is listless. All of this is because of the anemia. And on examination we find pallor, hepatosplenomegaly, Also, as the child gets older because of the iron overload, because of repeated transfusions, and as you said, because of the increased iron absorption, the iron starts depositing in all the organs and majorly affecting the liver, heart, and all the endocrine organs. And as you said, like if the mutations are similar for thalassemia in two children, can the clinical presentation vary? Yes, it can vary because there are certain contributory factors which alter the clinical presentation. For example, the presence of HPF. There are certain mutations or genetic variations in the values of HPF in the child. For example, there is a condition known as hereditary persistence of HPF. Because the HPF containing RBCs, which are usually known as the X cells, they have a longer survival than the other normal RBCs circulating in the thalassemia child.
So
Also,
all what you want to convey, it is not only necessary that we have the pathology in mind and the clinical presentation, but in addition to that, there are other contributory factors which can affect or change or modify the clinical manifestation. The immediate is the important one. The individual allele, they vary with respect to the severity of the biosecurity. Then, of course, gamma chain expression is elevated, more of HbF is formed, and hence less of severity. They all, vary in the severity. One is in the anemia, the other is the erythroid factor. Because the turmoil is in the marrow, and everything depends upon the severity in the marrow. So, therefore, the other issues that probability defects in an individual, because any free chain can be solubilized with the process of proteolysis, and one individual may differ in this proteolytic process from the other. So basically, this is what clinical deterioration. So how they can. So similarly, inheritance of more than one complement of that. So more of alpha hits and more of severity. So therefore, these are the issues. What is the burden of the disease?
so as far as India is concerned, it is known as the thalassemia capital of the world. And every year around 10,000 to 15,000 thalassemics are born. Burden is quite high.
I think it is 12,000 to 15,000 thalassemia majors are being born every year, and it comes to one thalassemia child after every 40 years. I think by the time of we finish this lecture, one thalassemia patient has already born. So this is the matter. And how many of them they have access to the treatment centers and candidate of special activities. Now thalassemia is not simply blood transfusion and iron. We have a multi-centric, multi-specialty follow-ups because blood transfusion iron chelation has prolonged the life by about 15 years or but thereafter 20, 25 or 30 years, most of the patients die of cardiac and other endocrine issues. So these are very important. Well, classifications and parameters which will then be based on the diagnosis. So what you want to convey any data you have in mind in classification. So that is you are describing in that way. But beta thalassemia, as we know, because this is interaction in the diagnosis. On the top, the PIF has given a classification that island carrier, asymptomatic, and no hematological features. I remember this term was written in John G. Miley hematology book when I was doing MD. And he had given the name thalassemia minima. Okay? I found these four terms only in that. Otherwise, thalassemia major, intermediate, minor, or greater. And today, they are having this stuff. It's very difficult to, to find out whether the patient is having this. So these are the traits, asymptomatic, and will have some calculated features that I was earlier asked. CBC, ARP, but meticulous screening of cases where I can say postgraduates are there. If you are screening a slide and you see hypochromia and microcytosis, so immediately one thinks perhaps it may be infection. But if you happen to see only just one cytopenic, basophilic cytopenic, that will rule out the possibility of iron deficiency anemia. Focus your attention towards the thalassemia. So that is why I was saying that you screen, if you see 100 slides, at least 2 or 3 slides you will have suspicion of thalassemia minor. That is how you can gain that experience. So this is that the intermediate and major. These are basically the phenotype associations with the. Now, the class hereditary persistence of they have kept this in the class. I don't know, although it's a separate entity, but I feel that so Dr. There are the diagnosis. What are just telling important CBC and
this is MC. This is a microcytic hypertrophy. MC we have to see the age cutoff. We are feeling in the children, so we have to see the age cutoff. MC will increase. MC is that is the age that also will increase as the age cutoff. And when we talk about the ranking count will also increase. And there is a distribution rate that will also be
yes. Focus your on some of these. This is very important. And of course, numerator cancer. This is, we are talking about thalassemia major. And these are the other parameters on which we can. Helpless males and bone marrow.
We see that genetically and spinocerebrosis because of the different size of the RBC and there will be microcytic hypertrophy. There will be some of the tear boxes. It's more like a target cells because the membrane of the RBC will be more prominent.
Yes, I think we have.
And it's very stiffening because of the aggregations of the ribosomes. We see that has been very well said in the first lecture also. The show of the pictures. Likewise in Jammu.
I come to Dr. Palvi. What could be the problems in the diet?
So the main
What are the solutions?
So the main problem I feel is the overlapping of symptoms. A child presents to us early, has signs of anemia, which could be pallor, reduced feeding, that is, which are same. Iron deficiency, could be there. So keeping her suspicion high and finding out the cause of anemia, doing ferritin levels, iron studies to find out if it's iron deficiency anemia, then taking detailed history, if there is any history of repeated blood transfusion in the family, or the ethnic group they belong to, and we all know we are in thalassemia prone region. So all this will definitely help us in finding out the patients early and doing the HPLC, neonatal
So
screening.
what the pathologist thinks the main culprit in the diagnosis, which creates problem in the mind of a pathologist or a hematopathologist, is if the patient has received the blood transfusion.
That is the most difficult.
So therefore, one, the anemic patient comes, don't jump and don't transfuse the patient. First collect the blood. But I will show you what happens. Now these are details, these are biological. Problem if age is below 6 months, it's difficult, either clinically and hematopoietic, because they will present when the gamma chain to a reasonable extent, and that is how these patients will learn. Repeated blood transfusions, very, very important. Then, of course, what we discussed in clinical heterogeneity is associated modifying factors and solution. Being the parent, being a mutation, and if these are not possible, and the patient has received the blood transfusion, wait and repeat the investigation after the age group. Okay. Now I will just briefly show you what happens if the child has received the blood transfusion. These are the normal values. Middle one shows the values of pre-blood transfusion. So straightforward values. All these features with our promotion discussed. But see what happens after the blood transfusion. Hemoglobin is increased, NCV, NCH, that's the distribution, and all these parameters will change. At that time, it becomes difficult to diagnose. Very well, blood. You see? Anisocytosis, nitrocytosis, they are almost gone. We will have only a 10 features, only a few. Cystocytes, I'll show how to catch a thalassemia in a patient who has received the blood transfusion if you are meticulously secreting this blood. This one, thalassemia major, received the blood and look the other vector parameters, but in between you find these two sites. Think about this. Probably it's a case of post-transfusion thalassemia. These are the other investigative parameters. The rest are whole cell. So what is the message? Message is Doctor and more briefly tell us how thalassemia intermediate is present and how it will be is different from thalassemia major. You focus on only those, how it differs from thalassemia major. Rest can be Dr. J.S. Arora sir. Thalassemia Welfare Society, welcome. Madam, आपका बहुत बहुत स्वागत है. Yes, please focus.
Thalassemia intermediate, basically the name itself says is between minor and major. So the symptom also presents like this, but the presentation age is different. That is, it starts around 2 years, below that, and the symptoms are not so severe. We say that it is blood transfusion independent per se, but it can multiple blood transfusion.
One is the age of presentation, then requirement of blood transfusion. What else? What other clinical features which are usually more seen in intermediate?
Mild anemia with slight of a growth stunting. That is the initial presentation of a baby when we see that mild to moderate anemia, growth stunting, and along with some changes in the cardiac structure like pulmonary.
Let's suppose leg ulcers. They are more seen in intermediate. Painful, difficult to cure. Pulmonary hypertension. Traumatic complication. And what is the difference of iron accumulation in the liver so far as thalassemia major and intermediate is concerned? While the iron gets deposited in intermediate and while it gets deposited in major.
As the liver is the major component where the iron gets deposited in the major thalassemia major, but here the extramedullary like bone.
No, in the liver. Distribution of iron in the liver. You see, thalassemia major, the iron accumulation is predominantly in the macrophages. Remember? And in intermediate, it is in the parenchyma. That's right. So that is these are some of these GMC curves. Now, this is typical case of thalassemia major. The F is elevated very much, and hardly you can see the peak of A. And then you have more as V8. Can you recognize this pre-integration peak? What is this? This represents what? Always remember these pre-integration peaks. This is an area usually in reference to this, it tells you the bilirubin. Otherwise, you can have fast hemoglobin, you can have hemoglobin H here in this. Okay? So that was it. Now we come to thalassemia minor. Dr. Sanjana. Any clinical parameter which will, you will suspect is the case of thalassemia minor.
Sir, thalassemia minor, usually the patient presents with only a mild leukaemia, usually between 9 to 10. And it is not as severe as in case of major. Also, when we go for lab testing, the MCV and the MCH are on the lower side. And on the peripheral cuts where we get a hypersensitive hypothalamic.
If you just have a suspicion, will ultrasonography help in this? You see, you don't have any organ, physical organ, everything is not there. But still, can you? No, in thalassemia minor, 30% of cases will show increase in the splenic volume. and it is increased around by 29.4%. And the spleen gets enlarged only when the spleen volume goes beyond 40%. So that's why we are not able to complete these. But spleen volume is already. So it's sometimes important. That will not be seen in iron deficiency. And you see, so important lab parameters.
So if you look for at the HP value, it is only a mild degree of anemia. And the RBC count is disproportionately higher as compared to the anemia that is present. The MCV and the MCH are decreased by the hypochromic picture. And particularly HP
What do you understand by borderline HPV? Suppose it is a 3.5 or 3.6, what you will like to do?
At this point, I have to differentiate it from iron deficiency, which is like what can I do for the CBC?
No, in iron deficiency anemia, if it is concomitant iron deficiency anemia, the A2 will not be 3.6. It will be lower. So if it is 3.6, what you will think about? You will ask him to take a normal hair day. Suppose it is a female. Always remember these borderline cases. There was a kid study in Bombay. Of the 249 cases around, or 230 or 149 cases, they showed thalassemia mutation. And 56 patients, they showed the normal. Now, if these patients are around, suppose the other partner is also carrying, you cannot stop with that, so that will be a tragedy. So, it means 149 cases have shown thalassemia mutation, but 56 have not. So, it means what are other determinants for HbA2 levels? They remain constant. One only thing to antibodies, once you see fetal hemoglobin 1 to 5%, don't jump to the conclusion of other things. Always rule out the possibility of stress levels. So these are the pitfalls that others you can do it. Because 8 levels, you can almost in the right.
So, what is there? We are talking about pitfalls in thyroid.
This is the pitfall. Right?
So, if there is a co-inheritance of alpha thalassemia, then alpha thalassemia can have a normal hemoglobin sometimes and a normal MCV. In that, we can have difficulty identification of that thalassemia. Or if there is an overlap in iron deficiency and chronic disease, in that case also we are difficult to identify. And if you are doing electrophoresis,
Delta thalassemia, you have to consider. Delta beta thalassemia, you have to consider. You have to consider the RBC morphology, CBC parameters, and hemoglobin F becomes important in situations where you are considering the possibility of alpha thalassemia. And then we can have beta plus signing variant, and these are the
and we have to do out with the genetic testing.
So these are, this is how we can rule out deficiency anemia. And why do you want to rule out iron deficiency anemia? We have already seen Dr. Chaudhary Saab, because these are you might unnecessarily give iron to a person who is thalassemia. And the person diagnosed as iron deficiency anemia will have basically thalassemia minor. The partner may also be a thalassemia minor. So these are the red indices should be interpreted with caution during these three at least. No one is a puzzle. I would like to these are hemoglobin C crystals. Yes. Fetal hemoglobin so much. Very little or no hemoglobin A. This is hemoglobin F. So possibility, it is perhaps normal size. So possibility, anyone? My son has caught it. If I say it's a cord blood or a 1-day-old child, so then it is perfectly normal. And then if I say it's a 10-month-old child having received 1 blood transfusion already, so then it's a thalassemia major. If I say it's a 4-year-old child, requires 1 transfusion 2 years back, so it's intermediate. And if I say it's an 18-year-old boy, then it could be hereditary persistent syndrome. So that is the importance of history. So always interpret these chromatograms with their proper history. Now this is a case. 32-year-old woman, 25 weeks pregnancy, EGB2, presently with jaundice history of multiple episodes and this. No, basically at the time of delivery she required some blood transfusions. In between, no blood transfusion. No organomegaly, no jaundice is there, no thalassemia faces. But it was there. Everything genetic count is 6%, ferritin increase and it. Now important HB analysis. HbA 91.2%, HbA2 is 5.1, it's elevated. HbF 3.7. So what we do? Right. This is straight. But clinically patient is not behaving like a crate. And hematological parameters are showing that this patient is basically a case of chronic hemolytic anemia. But it is not behaving in any way. So what would be the possibility? How we can move forward? If I say it's a co-inheritance of more than one complement of alpha G, this can also happen. So this is the answer. Okay? So these can be sometimes. I think these are yes. थोड़ी मुस्कुराहट को आ जाए चेहरों पे कि ये दो they are not my favorite so far as their performance in Bollywood is concerned. I have another. I am a big fan of someone else, but I am very much fond of them, and they are heroes because of two reasons. They both are beta thalassemia minor. Amisha Patel and this Mahanayak, Amitabh Bachchan. But they did not hide their history. One. Secondly, they followed the advice of the doctors. They are happily married. Abhishek Bachchan is also doing very fine, and he has also married Aishwarya. So what is the message? Message is that thalassemia carrier is not a disease. One, thalassemia carrier and discuss the issue, don't run away. Follow the doctor's advice. Now, critically, what I said, that there is widening of the marrow cavity. Now, if this is the normal skull bones. If this is like this, तो सूरत ऐसी होगी मुस्कुराहट. But you imagine these skull bones in thalassemia, there is profound erythroid hyperplasia. Marrow cavity is dilated. And are you aware of the diameter? Yes, just 2 minutes. Diameter of skull bones in medullary cavity and the long bones, the basic brunt is seen in craniofacial bones. And if there is erythroid hyperplasia widening, and what will happen? This will go like this. And look, if you happen to see the skull of thalassemia major, you see this is, if the bones will show like this, the appearance will be like this. So therefore, what is the message in the audience? How many of you have tested hemoglobin A2? Raise your hands. Sir? आप तो गुरु हैं सर. No, ऐसा वो तो मैंने भी किया है. But question is, अगर डॉक्टर होके हॉस्पिटल स्टाफ ने HbA2 नहीं किया है, तो किस हक से आप पेशेंट को कहोगे कि HbA2 कराओ? And you see, the thalassemia minor is asymptomatic. You are asymptomatic doesn't mean you don't carry this gene. And tomorrow, if the partner is also carrier, you see, I am not, घबराइएगा नहीं, आपको सतर्क कर रहा हूँ. And once the child is born like this, it is a colossal tragedy for entire family. And I'm cautioning you, go and test HbA2, नीचे HbLC पड़ा हुआ है, तो उसको कहिए. And what was this? Was the message by Abhishek Bachchan during this last year's Thalassemia Day. We don't want half life. If our parents can live full life, we don't want, the children want also full life. So all the parents have the responsibility to first get HB carrier tested and then plan for the family. Do genetic counseling if the other partner is also carrier. And you are having these facilities here. So therefore, आप पाप कर रहे हो उस बच्चे के लिए, and the entire family gets involved in this. So this is, and I had said, neither Amitabh Bachchan is my favorite so far as the Bollywood is concerned performer. He is my hero. Thank you. चलिए हाँ जी अरे
Very much, sir. Excellent moderation and nice contribution by all the esteemed panelists for such a difficult topic made so easy, particularly for residents. I must say, as usual, sir, your style we I can only say and conclude the section by saying that there are many variations, phenotypic variations, more than 200 gene mutations are there, noticed.
Yes, yes.
So a great synergy between the metabological lab, the molecular lab, and obviously now in the upcoming time, the genomic lab also is being beat up all. And I'm very happy that the person next to me has started this facility institution. With these words, I will say a few lines in your honor, and it would be my honor. अपना जमाना आप बनाते हैं अहले दिल अपना जमाना आप बनाते हैं अहले दिल these words are for you sir हम वो नहीं जिसे जमाना बना गया
हाय आफरीन है हुजूर आफरीन चलिए Oh.
So, what is your take about the surgeries for thalassemia, especially when it comes about between major and intermediate?
You see, the basic surgery which the thalassemia major surgeon is when hypersplenism is there to take. So splenectomy can be sometimes be done, but that has to be done very cautiously. You have to rule out first the accessory spleens over there and then move on. Then about surgeries are related to orofacial deformities where the dental surgeon or a maxillofacial surgeon comes into practice. And there could be other surgical procedures depending upon the, you see, thalassemia intermediate, the ulcer, leg ulcer, how you would plan? Will you start trimming or you just would like to treat it conservatively? These are some of the issues, and any particular surgery you want to discuss? Yes, those are there. You see, once the bilirubin is the high, stone in gallbladder they can be there. And these days, I think lab choles are being done and it can be there. But the caution has to be, and there has to be a definite, discussion. That has to be carried out. That depending upon the age of the patient, and then the follow-up treatments after spleen has been removed. So caution is always there. First, assess the patient.
Thank you all. We now request Dr. Sunil Sharma and Dr. Mohammad Raza, Professor, Department of Pediatrics, GMC Jammu, to please felicitate our chairpersons for the session. Dr. Sandeep Dogra.
आपको इधर देखिए इधर देखिए इधर देखिए इधर देखिए ये इधर देखिए यस यस ठहरिए 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 यस चलिए
Dr. Vishal Tandon.
अगर आप यहाँ साथ आए सारे ये हाँ जी यस
Dr. Salim Nasri.
सर चलो क्लोज क्लोज आओ क्लोज सर चलिए साथ 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 इधर देखिए चलिए क्लोज 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 इधर देखिए यस
Dr. Kaushal Kumar. Dr. Kavinder Kumar.
यस 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 हाँ जी देखिए हाँ जी ये यस
Thank you all.
As rightly said, prevention is better than cure. It is my privilege to invite and hand over the proceedings to our respected chairperson, Dr. Ashok Gupta, former HOD Department of Pediatrics, GMC Jammu. Dr. Mitali, Associate Professor Department of Blood Transfusion, GMC Jammu. Dr. Arshad Bhatt, Consultant Department of Radiology, SMCS Hospital, and expert in prenatal diagnosis. Dr. Sanjay Rana, Consultant Department of Pediatric Surgery, SMGS Hospital. Handing over to the chairperson.
GMC, Ludhiana, and now she is working in GMC, Ludhiana, as in water, that is what chemology, and looking after transplant.
Thank you, sir, for your kind introduction. So today I've been given this topic about prevention of thalassemia. So before I start, I think I'll have a couple of questions for the audience. How many of you amongst the audience are married? Raise your hands. How many of you are married? Okay, I'll do it the other way around. How many of you are not married? Okay. How many of you are married but not completed your family? Keep your hands raised, please don't put them down. Those who are not married, please keep your hands up. हाथ ऊपर. अभी मैरिड है लेकिन फैमिली पूरी नहीं हुई है. You're planning to have a child. Okay, nobody wants to tell. Now you tell me, out of all of you, how many of you are tested for HbA2? Nobody. So now you should listen to what I'm going to talk about. If you don't want to, see a child जो आपको अभी डॉक्टर कॉल ने दिखाया, अगर आप वो नहीं देखना चाहते हैं और शायद उससे नहीं गुजरना चाहते हैं, so please listen to me and stop chatting amongst yourselves. Right? Are we ready? Right. So when we talk of thalassemia, okay, we know hemoglobin disorders are the commonest single gene disorders. In countries like India, where we have a lot of infections, hemoglobin disorders do not get the importance that they should get. Hence, most of our children do not get the treatment that we need and suffer from lots of complications. If we talk of global burden, sir just spoke to us that thalassemia used to occur around the sea. That's why word thalassa came in. But if we look at the 2021 report, that difference between sea and not sea has, sorry, the pointer is not working. The difference between the sea and not sea has actually disappeared, right? So you see all the continents are in similar color of blue. And there are about 13 lakhs patients with thalassemia living with the disorder as of today, as of 2021. And Southeast Asian countries have the commonest incidence and prevalence of thalassemia in the entire world. If we talk of India, the carrier rate of thalassemia is 3 to 4. So यानी कि अगर हम इस पूरे हॉल में 100 लोग हैं तो 4 लोगों को थैलेसीमिया माइनर है और उनके घर में एक थैलेसीमिया मेजर बच्चा होने की पूरी संभावना है अगर आप आज अपने आप को स्क्रीन नहीं कराते हैं. But there are pockets, if you see Punjab, Gujarat and Northeast where there is a high prevalence of HBE, there is a different kind of distribution in our country. There are approximately 32,000 births of patients with hemoglobin disorders, and out of which 10,000 is nearly thalassemia births. And optimal care and allogenic transplants are available only to a few in spite of all the help that is available from the government. So when we talk of prevention, हम किसी भी प्रॉब्लम को डील करने की बात करते हैं तो हम 5 W's and 1 H की बात करते हैं. Why? क्यों प्रिवेंट करना है, किसको टारगेट करना है, कैसे प्रिवेंट करना है, किस टाइम टारगेट करना है. हम आपसे कह तो रहे हैं HbA2 कराना है, बट व्हाट इज द राइट टाइम टू डू दिस HbA2 टेस्ट, कहाँ पर करना है एंड कैसे करना है. सो वी हैव टू आंसर दीज क्वेश्चंस एंड एज वी गो थ्रू द प्रेजेंटेशन आई विल ट्राई एंड आंसर सम ऑफ दीज. So the first question, why? Is it worth it? So let's go through that. We have a high frequency in some of our states that we just saw. The prevalence of thalassemia trait is as high as 17%. I just looked up the JNK data after Dr. Kaul asked. The prevalence of thalassemia trait in Jammu is approximately 5%. That's the data that I just saw 5 minutes back. So if we want to prevent young children, young adults dying from thalassemia at the age of 30-40 years, we need to start thinking today that we do not add to that burden of patients who are already existing, so that the patients who are alive get better care, better facilities, and there is no shortage of blood for them. And the cost of prevention versus cost of treatment is 1:4. यानी कि एक बर्थ प्रिवेंट करने के लिए उतने पैसे लगते हैं जितने एक बच्चे को ट्रीट करने के लिए उतने पैसे लगते हैं जितने 4 को प्रिवेंट करने के लिए लगते हैं. So if you look at blood requirement, ये 2018 का नेशनल एस्टिमेशन ऑफ ब्लड रिक्वायरमेंट है एंड इसके हिसाब से एडल्ट्स में जितना भी ब्लड लगता है उसमें 8.2% hemolytic anemias को जाता है, एंड थैलेसीमिया बीइंग द मोस्ट कॉमन कॉज ऑफ hemolytic anemia in our country. And if you look at the same data in children, 22%, यानी कि हर 5 यूनिट में से 1 यूनिट जो भी बच्चों को चढ़ रहा है वो थैलेसीमिया के बच्चे को जा रहा है. सो अगर हम ये थैलेसीमिया को आज बंद नहीं करेंगे, कल को हमारे थैलेसीमिया बच्चों को ब्लड नहीं मिलेगा. सो दैट इज़ वाई वी नीड टू स्टार्ट थिंकिंग नाउ. दिस इज़ जस्ट एन एग्जाम्पल. अगर हम एक कैलकुलेशन करें कि हमारे थैलेसीमिया के बच्चे हर साल बढ़ते जाएं तो शायद इस रेट पे उनका ट्रांसफ्यूजन रिक्वायरमेंट है वो बढ़ता जाएगा. So this is a calculation that we did in our unit, that if we keep growing like this and not prevent thalassemia, we'll need 50,000 units of blood per year for just thalassemia patients, and the unit size was 250 to start with. This is not from India, but from the entire world. A report from 2021 which talks of prevalence of thalassemia. So if you look at the commonest age, it's still the maximum number of thalassemia patients are less than 5 years, and only a few percentage reach the age of 40 to 45. So if you look at the graph, it is like a pyramid. So there are many children who are dying in the childhood and not even reaching their adulthood, and that speaks volumes about care, not just in India but worldwide. If you look at mortality rate, just have a look at that bottom blue and green bar. How many young lives less than 5 years are just taken away because we do not have adequate facilities across the world to treat this disease? This is an estimate from our country. South India, more than 2,000 patients. Only 50% of patients born with thalassemia reach the age of 26 years. How many of us here are 26 years old? So we look forward to living a full life, right? So 26 is no age to die, and we will not be able to help our existing thalassemia patient if we keep going like this. And the rate of the chances of death increased if they have any of the following complications. Now we have talked about numbers, we have talked about complications, we have talked about mortality. But keeping a child alive, we have parents here, society members here. What does it take to look after a child with thalassemia? This is a study from a public hospital, a government hospital from Mumbai, which talked of all the costs that are included. These costs may be physician cost of the, going to the hospital, making an OPD prescription, the shared cost of doctors' pay, so these were, a split up, and the maximum amount goes to the shared cost, the cost of the hospital stay, the cost of the physician, the cost of the nurses. But if you look at the total cost, the total annual cost of treating a thalassemia patient in Mumbai in a public hospital per year is approximately 70,000. And they have not added the intangible costs, the cost of suffering, the cost of psychological, stress that they go. If you add that, we don't know where will this number go, right? So that, I think I've given you enough reasons to say why should we prevent thalassemia, right? So now, do you agree we need to prevent thalassemia? Do we need to prevent thalassemia? Yes. So how many of you will now go and get your HbA2 tested? Within a week. So we should get some phlebotomist here and get everybody's sample done right now. Right? Ready? Yes. Good. So when we talk of, now we know, yes, we have to prevent. Now we talk of strategies for prevention. हम कैसे prevent कर सकते हैं, and how can we help each other in preventing this deadly disease, right? We talk of health education. We talk of screening and diagnosis. Once we have educated, we have done screening, we need to do the genetic counseling. Then fetal sampling, we have an expert with us for that, prenatal diagnosis, and finally the surveillance of whatever activities we have done, has it made any impact into the population. So this is, about health education. So whom do you want? We are talking of health education. आज हम आपको ये lecture दे रहे हैं, but how do we reach everybody? So one way of doing health education is to do mass education. That means go and reach out to each and every citizen of India and tell them about thalassemia. It can be done in today's era using media, using social media, right? But what will be the impact? It will come in many, many decades probably. It won't start happening today. What is the easier way? If you have a thalassemia major child, you have the parents, you go back to the parents' family, father ke brother, sister, mother ke brother, sister, and then go back to that community probably, if that community has a higher. So we need to see which group of individuals we want to educate. And once you've made a diagnosis, we need to do a prenatal diagnosis. Now we talk of health education. Does it work? Has it been proven to work? Yes, health education has been proven to work in Mediterranean countries where termination of pregnancy is not possible. A lot of Islamic countries, it's not possible to terminate the pregnancy. So what they have done regular camps, they have educated not just the general public, students, teachers, doctors, everybody, and they have shown an impact that yes, education makes a difference, and then people come forward and ask about, mujhe screen kar do, right? And that is what we want from all of you today, that come forward and ask for screening. Then we have, once we talk of this man, universities, schools, colleges, we need a parent association and we need the society. आज आपने यहाँ thalassemia सुना है, you have to go and tell 3 more people at least that get yourself tested. So start with yourself and then tell 3 more people and tell them to tell 3 more people, and then probably yes, we will be able to reach out to the entire country's population. But remember, this will not stop here today. It has to be done over and over again in a sustained manner to achieve what the outcomes we want. So these are the different group of people we wanted to, we think we should educate. So has that been tried? It was, a questionnaire was given to group of high-risk population, that is Aurora community in North India, Delhi, and Rohtak, where they were asked about, thalassemia, would you like to get yourself tested? 50% of them refused. Knowing they are at high risk of thalassemia, they refused to get themselves tested and said, ये माँ बाप के पुराने कर्म है कि बच्चे को thalassemia है, इसमें कोई genetic disorder नहीं है. Even in Kolkata, 37% people had heard the word thalassemia, but only 10% knew that even a normal person walking and talking without any apparent disease can have thalassemia minor as well. This is from Udupi, and this is a latest study from 2022. The previous ones was like 10 years back. But has anything changed in 10 years? No. Even these young girls from Udupi, which is, a well-educated area, 27% refused to get tested, saying it cannot happen to me. So that's the status, that education only probably will not act, and we need a broader policy, but it has to go hand in hand. But whenever we go and inform the public, we have to give a clear-cut idea that we are talking of people in the marriageable age. That's why I asked you, आप में से कौन married हैं, childbearing age, जिनकी family complete नहीं हुई है, and then we also have to talk about terminating pregnancy. So suppose a couple is at risk and they are found to have a fetus with thalassemia major, will they be able to get a termination of pregnancy done for all the reasons that we have to see? And it has to be a multidisciplinary approach. It cannot come from individual doctors or individual societies. All of us have to talk about thalassemia in the public. Professionals have to be taught. There's so many doctors, physicians who are probably not pediatricians, so they don't know about thalassemia if they've not seen a child with thalassemia. They should know about the disease, they should know about the genetic counseling, they should know what is prenatal diagnosis, how it can pick up thalassemia, where it is done, how it is done, and what is the risk of prenatal diagnosis. And we need to have people like Sir in here who are trained in fetal sampling and making sure that if we tell a couple that you are at risk, we have a solution for them. If we talk the training in genetics, as I said, we should have all the outlets plugged in so that nobody who's at risk falls through that risk. So when we have done everybody, we have done the population, we have done students, universities, the NGOs have helped us. We still need to reach the policy makers, because no matter what we do at the ground level, if one letter comes from the government of India that everybody in this college has to get screened, I believe it will be done tomorrow. So we need to keep engaging with the policy makers. Also, doctors like us, we have to keep doing the scientific research so that we have these numbers. If nobody would have published that paper, I wouldn't know that 5% is the rate of thalassemia carrier in Jammu. So we have to see that there is, we have to keep doing this so that whatever programs we are implementing, we need to see what is the impact. So it is important that we engage in research. So that's about health education. Now we move on to screening and diagnosis. Now we said all of you now know about thalassemia. So we need to start screening. We have created awareness, we have told everybody, and now we need to start screening. So what are the different kinds of screening that we can do? One is mass screening. जैसे सर ने किया, आप सब में से कौन कौन थैलेसीमिया माइनर है, उन्होंने सबसे पूछा, right? That means हमने पूरी कम्युनिटी को पूछा आप में से किसने टेस्ट कराया. That's mass screening, right? मैंने क्या किया, आप में से कितने अनमैरिड हैं या कितनों की फैमिली पूरी नहीं हुई है. So what did I do? I targeted a population which is of interest to me because they will, they're likely to have a child in future with thalassemia major. Or we can do a cascade screening. I have thalassemia major, so मेरे सारे relatives को screen करते हैं क्योंकि there is a chance that it runs in my family, right? There are so many carriers in my family who don't know about thalassemia. Or we can do a newborn screening which applies mainly to sickle cell and not so much in thalassemia. So mass screening is said organizationally थोड़ा difficult है सबको screen करना. It needs a large amount of financial resources. And it is we can do this if we know, like Gujarat, there are smaller areas like Saurashtra which has 20% prevalence of thalassemia minor. So there you do a mass screening, it makes sense. But probably we can't spend so much resources in Jammu with 5% thalassemia trait prevalence. Gujarat has done a model of mass screening where they went with the Indian Red Cross Society starting right in 2004. They went out to all universities, colleges and screened a lot of thousands of young girls and boys, and the effect was that they have prevented about 560 thalassemia major births, and this is the information as of 2022 on the Indian Red Cross website. So now we talk of target screening, right? Target screening मतलब जो अभी हमने कहा जिनकी अभी मैरिज नहीं हुई है या जिनकी उनकी फैमिली कंप्लीट नहीं हुई है. So that can be done या तो प्री मैरिटल शादी से पहले, प्री कंसेप्शनल शादी हो गई है but उससे before we plan a family, and antenatal when somebody is pregnant, that's the time a target screening can be done. So this was tried in different ways. This is a very famous study from Dr. Roshan Kola done long time back where they screened a lot of school children, high school children with thalassemia, and 47 of them were diagnosed with thalassemia trait. So 10-15 years down the line they went back and asked them आपको thalassemia trait था, आपकी शादी हुई नहीं हुई, आपके बच्चे हुए नहीं हुए, and out of those 47, 35 remembered कि हाँ हमारा कुछ टेस्ट हुआ था. सिर्फ 12 को यानी कि 25% को याद था कि हम थैलेसीमिया माइनर हूँ. किसी ने अपने पार्टनर से ये बात डिस्कस नहीं करी, एंड उस 47 में से भी एक फैमिली को थैलेसीमिया मेजर बच्चा पैदा हुआ. So what we conclude from this is that one time testing and counseling does not work. So आज अभी जो मैं बोल रही हूँ आप सुन रहे हो, कल आप भूल जाओगे. So that is why Dr. Arora said 1 week के अंदर अपना HbA2 टेस्ट कराना है, right? So one time counseling will not work. Although such testings have worked in other countries, in Canada, France, but sadly not in our country. Premarital screening has been done in Middle Eastern countries. Cyprus has done that, China has done that, where you need to get permission from the government or from the church, and that's where how they ended up preventing a lot of thalassemia births in their community. A very nice study from Sri Lanka which came in. They started their thalassemia prevention program in 2005. They have about 1800 thalassemia major patients in 25 districts, and 5% of their annual budget goes to this 1800 patients out of 2.2 million population. So 2.2 million population का 5% health budget सिर्फ 2000 बच्चों को जा रहा है. So and between 2005-2015 they said whatever they were doing, it did not lead to any change in thalassemia major births. 10 साल का awareness, health education, screening, and no decrease in birth of thalassemia major. children. So their program, they realized their program was a failure. So they did some, public health statistics and decided to try 3 options. One option, do whatever you're doing already, don't change anything. Second option, आप 5 डिस्ट्रिक्ट में काउंसलिंग और स्क्रीनिंग कर रहे हो, इसको सारे 25 डिस्ट्रिक्ट्स में स्प्रेड कर दो. Cost was calculated and made sure that the coverage of target population screening was 95%. And third is antenatal screening. But in Sri Lanka, again, termination of pregnancy is not allowed unless and until mother's life is at risk or the baby is born of a physical assault. So that's why that option was calculated, but it is not, it can't be implemented in Sri Lanka. So what they found was that if they continued the same, they would be spending much less money, but the number of thalassemia major births prevented would be only 14 per year. If they increase the screening to 25 districts, so as of now, Sri Lanka has changed gears and started from policy 1 to policy 2 by adding some more money, because that will, ultimately it will be status quo, because they won't be spending so much money on treating children with thalassemia. Something similar started, tried in our country by one of our colleagues in South India called Dr. Abhilasha. In her hospital, she approached more than 700 antenatal women for screening for thalassemia trait. 15% refused to get tested. Out of those who were tested, about 16, whosoever was, the hemoglobinopathy rate was about 5% again. Then, they were asked to bring their husbands to get tested. 15% of husbands refused that, no, we will not get tested. Then they found out the antenatal couples and offered antenatal testing. And in that, again, 15% refused that, no, we don't want to get the fetus tested. But all this, the cost of prevention of a beta thalassemia birth turned out to be only 1,11,000. And compare it to the cost, it was 70,000 for 1 year treatment. So this birth prevented is much cheaper than, if you talk of health economics, it's a much lesser burden on our country's, funding as we compare to treatment. And we talked of, why they refused screening. Most of them wanted to seek permission from their family members. Some of them found it unnecessary, and, some of them didn't want to carry this pregnancy forward. We tried to look at our own population of thalassemia major, and this is for probably our society members to take forward. In DMC Ludhiana, we just questioned all our thalassemia major patients or their parents, how many relatives they have. So हमने mother को पूछा आपके कितने siblings हैं और उन siblings के कितने बच्चे हैं. हमने father से पूछा आपके कितने siblings हैं और उनके कितने बच्चे हैं. और जो thalassemia major birth का patient था उनके कितने siblings हैं. And we found out there were a total of 4,014 relatives who could have been screened, but only 10.8% had been screened. 90% in spite of repeated counseling, in spite of having a thalassemia major child in their own family, did not come forward, thinking that ये आपकी problem है, ये आपके घर में है, हमें कुछ नहीं है. And they will come forward if we go out. We could do this in COVID, right? एक कोरोना आता था, हम सबको पकड़ के उनका कोविड टेस्ट कर लेते थे. So अब अगर एक थैलेसीमिया है तो हम उनके आसपास जाके थैलेसीमिया टेस्ट क्यों नहीं कर सकते? Why can't this be made a policy, right? And there were 31 births of thalassemia major in this extended group, and these 31 births could have been prevented. And if you look, this is a graph showing that, what is the percentage. You see those small dark blue bars, this is the number of relatives who have been tested, and we feel it's a complete failure on our part that we have not been able to convince them for that testing. And most reason given was बड़े भाई बहन की शादी पहले हो गई थी, हमें बताने में डर लगता है, या हमें लगता है कि लोग हमसे डिफरेंशिएट करेंगे, हमारे साथ स्टिग्मा एसोसिएटेड होगा, या फिर अगेन वही कि हमारे साथ ऐसा नहीं हो सकता. Finally, when we calculated that if we would have screened this 4,000 patients, 4,000 relatives, and with a frequency about 35% that we found in that small cohort who were tested. And उनके हमें अगर siblings को भी test करना पड़ता और अगर आगे चल के हमें उनका antenatal screening भी करना पड़ता, the cost would have come around 1 lakh for prevention of those 31 births per birth. These are the different tests as per the NHM guidelines, but I think Dr. Kaul has already shown you HbA2 is the most reliable one. During pregnancy already MCV, MCH में बहुत change होता है, so it's very difficult to make a diagnosis of thalassemia trait in pregnancy. I would skip this again because Dr. Kaul has already taught you about MCV, MCH, and this is a study that Dr. Kaul was talking about, borderline HbA2. 3 से 3.5 के बीच में, right? So you look at this, the numbers in the last 14, individuals had MCV of more than 80 and, HbA2 of 3.5 to 3.9, and they had thalassemia trait. So if you have a person, if you have somebody who's thalassemia trait, if you have a doubtful HbA2 and MCV, there is a chance that we are going to miss out these patients, these people with thalassemia trait, if we use MCV of less than 80 and HbA2 of more than 3.5 or 4 also. So that's why whenever possible, don't just look at the HbA2 report, also take the CBC report. This has happened with me, that somebody came, they had a child with thalassemia major, they had done an HbA2 testing, HbA2 was normal, but the CBC report was screaming on top of its voice that no, I am a thalassemia carrier. There was microcytic, hyperchromic, and RBC count was more than 6 million. So don't just look at the HbA2 report alag se. Always ask for accompanying CBC report. Now coming on to the last, we have done awareness, we have done screening. Now finally we need to do the genetic counseling and testing. So there are laid down criteria that you should give a correct diagnosis when somebody is undergoing such an invasive procedure. There should be proper pre-test, post-test counseling. Also we should know if suppose somebody comes up with a disease, then what are the treatment options available? There may be instances when they cannot undergo medical termination of pregnancy, then you should be able to guide them. कहाँ पर treatment होगा, कैसे होगा, क्या cost होगा, right? So these are the different techniques that are available. I will not go into details of these. We also have now pre-implantation and preconceptional diagnosis where parents are opting for, it's not easy for somebody to go to undergo abortion, right? So they try and have a baby, have an embryo which is thalassemia free. This is one of the reports from Thalassemia International Federation. India has, the green color shows India has the capacity to have prevention facilities available, but they are disorganized and we need to put them together and have a proper national thalassemia prevention policy. These are the different countries who have shown it that it is possible. Cyprus, almost zero thalassemia birth by screening, creating awareness and antenatal testing. Sardinia, and you look at most of these programs, they are voluntary. Nobody forced them to undergo a test. These were voluntary testing and they decreased their thalassemia major births. So I hope someday we will be able to see a curve like this, and that will be a real victory of spending the day here today. And WHO again has laid down some criteria how to start a screening program, what are the optimal requirements, how to go about it, and finally, once you've done, you need to do surveillance to make sure what is the impact of the program, are there any weaknesses of the program, and is our approach to the, the target population fine, and we are not being too harsh with them. I would leave you with this message, sir's name as a take-home message. 1992, we said prevention of thalassemia a necessity in India. And 33 years down the line, I'm standing here and talking again about prevention. So now if we don't, get up and start working towards it, somebody down the line 30 years later will stand here and talk again about prevention of thalassemia. And that's something the younger population has to stop. And I'll leave it there. Thank you.
Thank you so much, ma'am, for such a wonderful presentation. It was simplified, elaborate, emphasizing the importance of prevention strategies, and I hope all the audiences, especially the students looking at the back, they understood the importance and they get themselves tested as soon as possible.
Thank you, Dr. Shruti, for your presentation. I have a question which is more of an ethical or you can say legal issue rather than technical. Since you said that we can go for pre-marital screening, so should we really encourage pre-marriage screening with the probable couples? Is it ethically and morally and legally correct?
So, ethically, legally it is absolutely valid. Many countries have done it. Ethically, if it prevents lifelong suffering, it is, we are not telling them not to get married. Even if two thalassemia minor individuals want to get married, we are not telling them don't get married. Please go ahead, get married. But when you are pregnant, please come back and get your antenatal testing done or screen your baby for thalassemia major. So yes, we are not stopping you. इस बात से नहीं डरना है कि minor आ गया तो शादी कैसे होगी. And that reminds me of a very famous quote. I remember Dr. Sopti, my teacher, my mentor, used to say, अगर screen करना है तो boys को करो, girls को नहीं करना है. इंडिया में पहले ही लड़की छोटी है, मोटी है, काली है, ऐसी है, वैसी है, ऊपर से thalassemia minor है. So the burden of screening goes to boys. There is no legislation, and I believe Dr. Arora has made a very good point. We are talking of girl empowerment, right? So I remember what I just said is, what ma'am used to say 20 years, 25 years piche, right? Today we are talking of girl empowerment, and all the girls sitting here. How can somebody tell you thalassemia minor ho to tumse shaadi nahi karunga, mat karo, I'll find a better person, right? But get yourself tested and make your choice.
I will just give you the suggestions how we can prevent it. Because what is a straightforward situation is always complicated. We are not able to convince the people to come forward. There was very reluctance in raising the hand. Why my hand was not raised earlier? Because it doesn't matter. I think legislation has to be given. Every child, when he or she is in the 11th standard, because there is no much stress of study, all the children should be screened for HIV. And all those who come positive, their parents should be counseled. Nothing has to be discussed in between. Remember your carrier status. Utilize this information at the time of marriage. Now, one comes to if a carrier is there, do not marry again. Now, if on one side we say thalassemia carrier is not a disease, and at the same time we keep a bar that thalassemia carriers should not marry. Because we have already many things, once we discussed at family level, that marriage proposals are coming. This is my practical example at Lady Harding. I was there as practical examiner in Jammu. They had recently purchased at GMC this bioweapon. And they did a screening among this residents. I asked the man, how many were carriers? He said only one girl was. I don't know what happened then. Did she convey the message? She told me, no, I have not asked. I will ask her. She was called. I said, marriage proposals are coming this way. See, this is the more thing one has to understand. Why I showed the picture of Amitabh Bachchan and it is just to tell you that it is not a disease, nothing you can move forward. Yes, telling someone don't marry a carrier is something putting a stigma sort of thing. Tell them, no issue. Remember, marry, but do a screening before you plan. And one, I think couple of years, Mr. Sethi and that conference was in Hyderabad. When we also gave right that there should be a legislation, mandatory screening of pregnant women who come. And I think only legislation can come. And we have to frequently talk about this. We have to frequently discuss about it. And so far as our medical college is concerned, when the MBBS student is promoted to the second year, third year, when pathology they have to study, screen all of them are educated. And that is how, once we discuss these issues on number of days, that will be helpful because nothing will happen. Societies have to play a major role in the we have to go to the public every time, repeat it, and tell them that do not be afraid, come forward and be a good family, happy family. Otherwise, until you see, every one of us know that if we don't wash our hands, we will fall sick by eating something. But this doesn't work. But if you show them, scrap their hands with a slide, show them the organism under a microscope. आपके हाथ में क्या है, ये तो घूम रहा है, अंदर ये कीटाणु है, और ये चीज जो है only then this will. Otherwise it's very difficult.
Actually, we are having antenatal detection of thalassemia major fetuses, and now we are detecting carrier couple retrospectively. So you are right, we should have a legislation over this, and every couple which is being taken care of by the tradition, they should be offered prenatal carrier testing. That's the only way we can prevent this.
Yes, every couple has to be before.
Yesterday, we and Sandeep sir, we came across a couple who were being tested for some other reason, and they were found carriers, thalassemia carriers. And they were later, once they were detected, thalassemia carrier, then they were offered prenatal testing for the latest.
At least those couples who have one affected child, they have to go for prenatal diagnosis. There's no issue. Screening for both the couples and what the madam was talking about the prenatal and pre-implant diagnosis. They're talking about it that we can ensure a healthy embryo. And then we also can have ensure for those couples who have already an affected child, that is thalassemia medium child, this pre-implant diagnosis nowadays have HLA match examination so that he or she, the new child, becomes a important donor for this.
We did a workup on school children, difficulties, we need a permission from the parents to draw the son. Cooperation of the principal. We were giving them one to
young बच्चे कहाँ सुनते हैं?
even if we did counseling, and then when we did the later part of our research, we simply learned what was found in profile. The question is, prevention is essential. I think the legalization, no government will do. It has to be voluntary. I think the societies play a major role. And today, you know, it is offstanding people. I worked at places, offstanding people say SPH is too expensive. I sat on office. They say we get 4 times ultrasound, the blah blah test. They say how much it cost? Landing up to 5,000 plus. I say the SPH costs 500. Where is the cost? Because the question is mindset. We need to make it even good. And the societies which are the one who need play a major role. We as a doctors are responsible. We need to work as a good team with the doctor. So even obstetrician gynecologist will not listen to you. I have already discussed, I'm sure you must
Done that,
have
yes.
experience. There are police, they say nothing. Did nothing happen. The question we need to increase awareness, counsel, and work.
Sir, as doctors and societies, this is just a thought. I believe we are not using our social media platforms enough. That's something we need to do.
See, everybody says doctors, general, or God. How many times we have got doctors in the corporation of lead and screening? We see, when we go any corner of doctors, I keep on talking everywhere. Unless we do this or
Our excellent presentation. I think since we have started in 1995, our main emphasis has been on the prevention and to create the society also. If we cannot prevent it, I think then we cannot increase our disease of the families, of the children, of the society, of the country. Health budget also will go like that. We may ask any guidance from the government, but government has given a lot of facilities like drug also. But drugs also have their own problems. Blood is a lot of blood, and we suffer this problem. Despite all those, we cannot reduce the psychology and everything. So prevention is the only. It may be any society, whether to follow or not to follow. Then it's their choice. And all somebody know their status, they have to part carry. Let them get married, no one body prevents them. Even thalassemia later and one month later also carry. But only thing they have to keep in mind that once they go by family, they have to let them because I visited a country which was the capital of thalassemia in 2000, Cyprus. Cyprus, now there is things that come, that was the first country in the world that took a decision that there will be zero birth of the thalassemia by taking 20 measures and do the accident rate. So since then the birth rate has gone zero, there 40% of money was spent on this only thalassemia is spent. So we have to learn the lesson. We are also listening. We cannot force only we can educate discuss and learn each other so that so somebody can power. He also and the family also.
Thank you all. We now request our chairpersons to please felicitate our speaker for the session, Dr. Shruti Kakkar.
I now request Dr. K. Cole, sir, and Dr. Sanjeev Digra, sir, to please come on the stage and felicitate our chairpersons for the session. Dr. Ashok Gupta, Dr. Mitali, Dr. Arshad Bhatt, Dr. Sanjay Raina, thank you all.
So, and especially sometimes it raises high blood pressure. So before giving injection, one has to check the blood pressure so that it is high. You just get the patient relaxed, wait, and after that it can be given.
Thank you, sir. You are insightful and engaging presentation. When you many more
Now I would like to invite Dr. Sanjeev Degra and Dr. Sunita Sharma to kindly come forward and felicitate our chairpersons on behalf of the organizing team. Dr. Nusrat, Professor, Department of Pharmacology, GMC, Jammu. Pediatrician. And Dr. Rajesh Cole, Senior Pediatrician. And Dr. Narendra Singh, Associate Professor, GMC. Thank you, everyone.
I request all of our esteemed guests and everyone present here, let's stand together and observe 1 minute silence for all those who lost their lives in innocent killing in Pahalgam terror attack. मैं सभी से निवेदन करता हूँ कि अपनी जगहों पर खड़े होकर 1 मिनट का मौन रखकर हमारे पहलगाम terror attack में जितना भी जितनी टूरिस्ट का मान सम्मान के साथ हुआ। बहुत बहुत धन्यवाद कि अपनी जगहों पर था। Assalamu alaikum, hello and welcome to a energetic and vibrant afternoon, ladies and gentlemen. I have also as a most beautiful gathering, feeling proud to be here in such a celestial and symphonious gathering of intellectuals who with their fresh expressions enhance the beauty and energy of this stunning, fabulous and vibrant afternoon. Your Majesties, Your Royal Highnesses, on behalf of the organizing committee of this program, I welcome you all with an open arm in the city of Apples, crown of India, paradise of Jammu and Kashmir. आज कोई तितलियां और खुशबुएं नहीं, बल्कि चांद को गवर्नमेंट मेडिकल कॉलेज जम्मू। सर, मैं इस मंच से आपका बहुत बहुत स्वागत, बहुत बहुत अभिनंदन करता हूं कि आपने अपना कीमती समय देकर हमारे इस कार्यक्रम को जो रौनक और शोभा बख्शी, हम उसके बहुत ज्यादा आभारी हैं। मैं निश्चय के साथ प्रिंसिपल एंड डीन गवर्नमेंट मेडिकल कॉलेज जम्मू माननीय डॉक्टर आशुतोष गुप्ता का इस्तेमाल करता हूं, उन्हें निवेदन करता हूं कि कृपया मंच पर उपस्थित होकर आज के इस कार्यक्रम को बढ़ाएं। सर, 100 चांद भी चमकेंगे तो क्या बात बनेगी, 100 चांद भी चमकेंगे तो क्या बात बनेगी, आप आओगे इस महफिल की औकात बनेगी। एक बार जोरदार तालियों से हमारे आज के माननीय मुख्य अतिथि प्रिंसिपल एंड डीन गवर्नमेंट मेडिकल कॉलेज। आज के इस कार्यक्रम की बहुत ही खास माननीय अतिथियों में उपस्थित, चूंकि मेरा ताल्लुक भी वादी चिनाब की खूबसूरत सरजमी डोडा से है, so I feel honored to invite on the stage Dr. राकेश द्वाल, प्रिंसिपल गवर्नमेंट मेडिकल कॉलेज डोडा। सर, मैं डोडा की सरजमी से मोहब्बत और अकीदत का सलाम लाया हूँ। सर, उनको तारीफ की जरूरत नहीं होती, जहाँ से भी गुजर जाते हैं बैठ जाते हैं। सर, आपका बहुत बहुत स्वागत, बहुत बहुत अभिनंदन। सर, आपसे भी निवेदन है कि मंच पर उपस्थित होकर हमारे आज के कार्यक्रम की रौनक करें। बहुत बहुत धन्यवाद, बहुत आज के कार्यक्रम में एक और बड़ा नाम मैं इस मंच से उनको सबसे पहले बधाई पेश करता हूँ। इससे पहले भी हालिया दिनों में यहाँ कॉन्फ्रेंस हुई थी। सर, मैं बधाई पेश करता हूँ आपको कि एसएमएस हॉस्पिटल इतने खूबसूरत कार्य कर रहा है। मैं आपके बीच तालीम की जोरदार बीच आवाज देना चाहूंगा मंच के डॉक्टर दारा सिंह, सेमी कोऑर्डिनेटर मेडिकल स्टूडेंट एसएमएस हॉस्पिटल। सर, आपके आने से खुशियां भी हमारे इस कार्यक्रम का हिस्सा बने। आपका बहुत बहुत स्वागत, बहुत बहुत अभिनंदन करते हैं। माननीय अतिथियों में उपस्थित एक और बड़ा नाम, आज के इस कार्यक्रम के मेजबान डॉक्टर जीएस सैनी, ऑर्गेनाइजिंग चेयरपर्सन। सर, आपका भी बहुत बहुत स्वागत, बहुत बहुत अभिनंदन करता हूं कि आप मंच पर उपस्थित होकर आज के इस कार्यक्रम की रौनक बने। इस मंच से मैं माननीय एक ऐसी शख्सियत को आवाज देने जा रहा हूं जिनका इस कार्यक्रम में सबसे ज्यादा योगदान है। उनकी मेहनत और लगन का नतीजा है कि इतना खूबसूरत मंच एसएमजीएस की सरजमी में सजा है। मैं आवाज देना चाहूंगा डॉक्टर संजीव डिग्रा, ऑर्गेनाइजिंग सेक्रेटरी। एक बार जोरदार ताली के बीच मैं उनका अभिनंदन करता हूं, वंदन करता हूं, निवेदन करता हूं कृपया मंच पर उपस्थित हो जाएं। हमारे आज के मंच पर उपस्थित गणमान्य अतिथियों को आज के इस कार्यक्रम में संबोधित किया जाएगा। मैं माननीय हमारे जो आज के इस कार्यक्रम के हमारे साथ जुड़े हैं, मैं उनसे निवेदन करता चाहूँ बुके देकर आज के कार्यक्रम के माननीय मुख्य अतिथि को संबोधित करेंगे।
डॉक्टर आशुतोष गुप्ता, प्रिंसिपल एंड डीन जीएमसी कॉलेज। डॉक्टर राकेश बैर, प्रिंसिपल जीएमसी डोडा। डॉक्टर दारा सिंह, सीएमई कोऑर्डिनेटर, मेडिकल स्टूडेंट, एसएमजीएस हॉस्पिटल। डॉक्टर जीएस सैनी, ऑर्गेनाइजिंग चेयरपर्सन। डॉक्टर संजीव डिग्रा, ऑर्गेनाइजिंग सेक्रेटरी, प्रोफेसर एंड हेड डिपार्टमेंट ऑफ पीडियाट्रिक्स, GMC।
धन्यवाद। एक बार जोरदार तालियां अपने लिए भी बचाइए, हमारे लिए भी बचाइए। मंच पर उपस्थित सभी मेहमान आइए।
We would like to extend a token of appreciation to Dr. Fayaz Bani. Dr. Fayaz Bani. We would like to appreciate a token of appreciation in the form of floral bouquet presented to sir by our esteemed chief guest, Principal and Dean GMC Jammu, Dr. Ashutosh Gupta. We would also like to invite Dr. Devraj Dogra, Professor and Head, Department of Dermatology, SMGS. Dr. Devraj Dogra.
डिस्प्ले ਵਿੱਚ ਲਬਾਣ पहले भी डिस्प्ले लबा
आइए आज के इस कार्यक्रम की शुरुआत करते हैं। हमारे हिंदुस्तान में परंपरा है कि हम जिस भी कार्य की शुरुआत करते हैं सबसे पहले ईश्वर अल्लाह भगवान उनको याद करते हुए, उनको नमन करते हैं, मैं मंचा से सभी गणमान्य अतिथियों से निवेदन करता हूँ कि कृपया दीप बजने के साथ आज के इस कार्यक्रम की शुरुआत करें।
कैमरा पर मोबाइल आगे से नहीं ट्राइपॉड पर देना ट्राइपॉड पर ना
Thank you all. Moving forward, we would like to start this inaugural session with a few welcome words by our respected Dr. GMC, ex-professor and head department of Pediatrics. Sir, please.
Good afternoon, everybody. Esteemed chief guest, Dr. Kesh Bahal, Principal, GMC Doda, Dr. Dara Singh, Dynamic Medical Superintendent, Dr. Devraj Dogra, HOD Dermatology, Dr. Fiaz Wani, HOD Medicine, Dr. Sanjeev Digra, HOD Pediatrics and Organizing Secretary, and the faculty, esteemed faculty which have come from all over India. Dr. Suri's VP Chaudhary is there, Dr. Resh is there, Dr. Kolsa is there, and the members of the Thalassemia Society, Hemophilia Society, faculty members, and parents, my dear students, I welcome you all to this update on hematology. As you know, the Department of Pediatrics has a dedicated department of hematology comprising of thalassemia, hemophilia. We have around 400 patients of thalassemia, the blood disorders, of which more than 300 thalassemia, and we are giving free of cost blood transfusion to every child. That is a great thing. The initiative was taken by our predecessor HOD, Dr. Ashok Gupta, and this is being carried out by Dr. Sanjeev Digra. And all the drugs which are the chelators, they are provided free of cost. There are twice a month, there are follow-up camps also, and the faculty from the national faculty, the experts, they are visiting, I think, twice a year for the checkup of these children, and they guide us. Similarly, we have a good hemophilia center also in our departments. Around 130, more than 135 patients are there, and adult hemophilic, they are also there. We are providing them and each and everything is provided free of cost. I can share one. I had one patient around 1 month back. They belonged to Amritsar, and the baby was around 6 months old, and we wanted to help them by giving Hemlibra. They went to Amritsar, but Hemlibra was not available. So this child got registered in our center, and the child is getting free of cost this Hemlibra. We have factor 8, factor 9, Novo 7, and all the factors are available. Even this Hemlibra is quite in good number, it's available. This is due to the help of our administration. Dr. Ashutosh Gupta, he is very generous and he's helping us, and we have the dedicated daycare center, and we are having the monthly follow-up also. The patients are coming for the follow-up. The problems of the patients, whether medical problems or any related to the hemophilia, any prophylaxis, this is being provided to them. I hope this CME today, this is going to guide us regarding update us regarding the management of these patients. With these words, I wish all the best for this hemophilia update, and I congratulate the organizing team, Dr. Sanjeev Digra in particular, who has done such a hard work for this CME. Thank you very much.
Thank you, sir. Your words are like blessing to all of us. Moving forward, we would like to start with the opening of thalassemia guidelines, hemophilia guidelines, sorry. We present each of the dignitaries and request them to open the guidelines.
So, for long, we have been managing hemophilia patients in Kashmir and in Jammu, but we were seeing that there was a little bit of difference and disparities between the two. So now we have tried to make a uniform guideline based on the HHCN guidelines, which have been laid down by the HHCN, the founder president, Dr. Naresh Gupta is here, Dr. K. Kaul sir is here. So based on those Indianized guidelines, we have tried to make it a like uniform thing for a whole UT of J&K. Dr. Sheikh Bilal, he is also basically coming, right? He has landed. He might be in a very short time in the auditorium also. So, but we'll keep on modifying it time to time, but this is to start with. So, I request Principal Sir and everyone to please release these guidelines.
We now invite our esteemed Principal and Dean, Dr. Ashutosh Gupta, to grace us all with his few words and insightful lessons.
So good afternoon, and again wonderful to be in this hall, second time I think within a week's time, and it's a very important medical CME, especially on hematological disorders affecting those patients which are supposed to live longer and have a normal life, and both the diseases, the conditions, I won't call them diseases, right? They are conditions. One is hemophilia, one is thalassemia. So how I am in sort of getting familiarized with the progress how these patients make, and the new molecules which are coming, the medicines which are coming, which make them live as normal as any other person. I am, as an oncologist, again when I practice oncology, again once we know we can't cure a patient, we try to make the disease chronic. That means patient may not get rid of the disease, but they live with the disease as normal as any other. Or complication like a hemophilic attending to the emergency with a lot of bleeds. So prophylaxis and preventive medicine, the science is changing. We are now moving from disease to a preventive sort of health process. Same thing happens in my oncology, my field also. So we are will be very happy to adopt these medicines, provided the experts convince that they really mean a value for the money. As you told that the need for transfusion go down, or for a hemophilic, if they don't bleed unnecessarily, the children attend their classes, schools, there are no misses, they don't end up in emergencies, repeated problems. So although the cost is exuberant, I tell you, for each patient you spend not less than lakh of rupees. And can we afford that? Actually, as a health planner, we have to think that way also. Can we? So that's why it's important to have small groups actually, and so that your case, your cause is projected at the right place. The government of India has to give money because states don't have this much amount of money. The same problem I'm facing for our hemophilics also, are trying to arrange funds. But definitely we are on the job, and I hope we won't disappoint our hemophilics or thalassemics or any other group of patients who can supposed to have normal life if we use these medicines. So again, congratulations to the organizers, Dr. Sanjeev, Dr. Saini, and all senior people sitting here. They are doing a wonderful job identifying the groups, the patients, the people who require these medicines and dispensing them in a proper way. And second thing, I'm very happy to announce today that we are going to start a genetic clinic. Very soon, Department of Pediatrics, Arshad is there. Am I right? So we had a conference also on that recent times, few days back, and as a result of that, we will be having genetic clinic. कहाँ पे करेंगे? Pediatric OPD, and please try to make it more popular. The message should not stay within the hospital; it should go out. Those people who require it should reach the clinics, and they should get the message. And a request from our medical student that we should have a permanent wall here like this. Thank you. Make this hall, auditorium modern, because it is being used very frequently. I am very happy that we should come here, assemble here again and again, so that it should be totally modernized. Thank you.
Thank you, sir. I now request Dr. Ashutosh Gupta. We now will begin with a session of giving out token of appreciations. For that, I request Dr. Sanjeev Bigra, Organizing Secretary, and Dr. G.S. Saini, Organizing Chairperson, to please felicitate our Chief Guest Dr. Ashutosh Gupta, Principal and Dean, GMC, Jammu. Thank you, sir. We now request Dr. Ashutosh Gupta to please felicitate our dignitaries, Dr. Dara Singh, Dr. Rakesh Bell, Dr. Rakesh Bell, Dr. Dara Singh, Dr. G.S. Saini, Dr. Sanjeev Digra,
हाँ जी डॉक्टर इधर देखिए इधर देखिए इधर देखिए इधर देखिए यस खैरिए खैरिए आंखें बंद हो गया हाँ जी अरे चलिए
Engineer Sudhir Sethi, President GMC Thalassemia Welfare Society, for his invaluable contributions towards thalassemia patients.
पकड़ी 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 इधर देखिए मेरी तरफ हाँ जी यस यस हाँ जी यस 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 यस
Shri Rajendra Patil, General Secretary, JNK, Thalassemia Welfare Society. Sir, please. Shri Rajendra Patil. Shri Rohit Tindiyal, President, Hemophilia Society, Jammu.
सर लो लो हाँ जी यस
The society, like we were earlier discussing about the role of society in prevention of thalassemia. So they are great role and they are really doing a marvelous, tremendous work. In this year only, till date they have organized, I think, more than 12 blood donation camps in last 3-4 months. Similarly for Hemophilia Society.
देखिए इधर देखिए सर क्लोज आई साथ से साथ ये उधर देखिए इधर देखिए ठीक है यस 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 चलिए
Shri Jagdish. Congress Secretary, Hemophilia Society, Jammu, and Vice President Finance, SFI.
सर क्लोज 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 इधर देखिए इधर देखिए इधर देखिए इधर देखिए इधर देखिए हाँ जी सामने एक मिनट इधर यस
We now extend a token of appreciation to all the nursing officers and supporting staff who helped us through it all. We welcome on stage Dinakshi Sharma, Senior Nursing Officer. Dinakshi Sharma.
हाँ जी यस
Sana Kaushik, Junior Nursing Officer. Latika Sharma, Junior Nursing Officer.
यहाँ से अच्छा आप आगे इधर देखिए यस
Julia Naz,
weird turbans are the ones clad in saffron may reflect that we belong to different social backgrounds. But ladies and gentlemen, the only one word that blends us all together into the beautiful amalgam is India, and that is the very identity of our land. वो हिंदू हो या मुस्लिम हो, सभी का मान रहता है, किसी के घर में गीता है, कहीं कुरान रहता है, किसी का कोई मजहब हो, सभी से प्यार है उनको, हमारे दिल में तो हर वक्त हिंदुस्तान रहता है। मैं राष्ट्रीय गान के लिए, नेशनल गान के लिए मंचा पे उपस्थित सभी गणमान्य अतिथियों के साथ साथ हमारे बीच उपस्थित सभी मेहमानों से निवेदन करता हूँ कि अपनी जगहों पर खड़े होकर भारत की मान का और एकता की जिंदा मिसाल दें।
We now request Dr. Sanjeev Nikra, Organizing Secretary, Professor and Head, Department of Pediatrics, SMGS, please say a few words.
I am here to just extend more thanks to all of you.
माइकल आ रहा है ये भी दिखाई न्यूज रिकॉर्डिंग कर
Dr. Anita ma'am and our esteemed guests that have come on from Delhi, Dr. B.B. Chaudhary sir, Dr. Naresh Gupta sir, Dr. G.S. Sarda sir, and my dear friend Dr. Bilal Sheikh sir, and all the dignitaries on the dais and off the dais, and dear colleagues, dear students, dear friends. So, this event, basically this dermatology update was organized keeping in mind that 17th of April was the World Hemophilia Day and 8th of May is going to be observed as World Thalassemia Day. So, we thought that in between we can just observe both the events and we can discuss the various challenges which we are facing in the management of thalassemia and hemophilia, and like Dr. Shruti Kakkar already expressed concern about the state of the prevention of thalassemia. 30 years back, B.B. Chaudhary sir said that prevention is the key to basically management of thalassemia. But today also we are discussing the same thing, that how to prevent it and what are the strategies we can adopt to prevent thalassemia. So, thalassemia is major. If we talk about GMK, it is the major, you can say the problem of the Jammu province. Kashmir, thalassemia is negligible. I think you have only 10-15 patients over there, and we are having about 400 patients over there. And lot many patients are even underdiagnosed also. We are not able to diagnose them. And on the other hand, hemophilia is like equally prevalent in both areas. But when I looked at the data from Jammu province, I found that the majority of patients they are living from Jammu, followed by Udhampur. So that was, it looks strange. But then I feel that might be this emphasizes that we need to improve our diagnostics and should extend this to the foreign places also, places like Doda. Now we have the blessing in disguise is now that we have medical colleges over there. Like in Doda we have a medical college, in Rajouri we have a medical college, in Katwa we have, in Jammu we have. So at least we can just discuss and we can think of that how we can establish the comprehensive thalassemia and hemophilia daycare centers in at least in these newly created. This can be further extended to district levels. So that was an idea to basically hold this CME, and we have selected the topics also, keeping on this all in mind, like establishment of centers and prevention of thalassemia and prophylaxis for hemophilic patients, and how to make the budget, how to make the demand for these various factors, because they are really costly. It really becomes sometimes difficult for the treating doctors to that how to basically decide that how much is to be ordered for what. And for that purpose, we have also taken the help of the guidelines created by SCCN. And so, hopefully, I think the next few hours we will be devoting to hemophilia, thalassemia we have already discussed. Hopefully, we can find out some. And with collaboration, we will be conducting these meetings on Monday, every Monday, and on Thursday afternoon as a follow-up meeting. And two of the genetic counselors, they will come in, and our neonatologists and our pediatricians, they will be collaborating with them to conduct these genetic counseling meetings. So once again, I thank you everyone that you come over here and you made this event successful. And I now request everyone to please. Lunch is ready in the TNT OP area, and please join us for the lunch. And at the same time, I again thank the J&K Thalassemia Welfare Society, the Jammu Hemophilia Society, Jammu Hemophilia Federation Society, and the hospital administration and the media persons for covering this event and for supporting this event. Thank you. Thank you so much. The request to please come back within half an hour so that we can start earlier. And after this lunch session, we have very interesting sessions. 3:30. So okay. So we will be back by 3:30 because Dr. Varun has to catch his train also. 3:30 will you no? I think he will not do. So 3:10. I would request everyone to please come back by 3:10. Then only we will be able to listen to him, and he has to speak on a very important issue. inhibitors form the 30% basically. So 30% of severe hemophilia A will have inhibitors. Now, what are the parameters you would like to consider? So the parameters would be again in terms of safety, efficacy, cost, and affordability. So availability. So availability, as I already get to know from Sani sir and Sanjeev sir, availability is not a concern in J&K as of now. But we believe that in the coming times you will also face the problem which everybody is facing, sir. Right now in Punjab we are dealing through. In Kashmir also, sir, understands that there are so many problems which are being faced because they say कि यार तुमने पहले इतना बजट मांगा एकदम ऐसे कैसे हो गया? So they are not trying to understand that we are trying to decrease the budget requirements in the coming time. So we will be discussing with this. So now let us assume a very simple situation. So government is allocated an amount in this budget. So you have to utilize this budget to indent the factor, whatever you want to buy. So how will you divide these factors of this budget? So you have all these availability. So how do you get whatever you want from this PD? Okay. So now let us assume that there are some number of patients of India A, some are with B, and some children less than 20 kg, and some with inhibitors. Now how do we reasonably allocate? So for example, you have 100 patients. I would like to show you this. Okay. So I would like to thank Dr. Joseph Johnson for giving this wonderful solver equation-based program in which you can put in the data and you can get. So this is when there is no constraint. You see this one. So when there is no constraint for 100 patients, if you have divided them into the number of patients and you have allocated and set the constraints, like for hemophilia A, you are not giving more than 50,000, more than 10,000 IU per year, or more than 5,000 in case of EHL per year. So why did we do 10,000, 5,000? So this was deliberately done. Because right now, the EHL factor is 2 times costlier, factor 8 ki baat kar rahe. So 2 times costlier than SHL. So that is why we have kept it like 5,000 ki requirement and 10,000 ki requirement. And as I know, you will also be sailing through the same boat that SHL is not available anywhere. So the companies have stopped supplying SHL. PDHL is not available anywhere. So we in Punjab had to, yesterday only contract was signed for getting 3,000 vials of EHL factory. Because SHL kahin se nahi mil raha tha, we were trying the factory for last 2 months. So how we have been managing patients, we know. So they were always on our hand. So if we put in these data, so we have done the cost also, costing also. So we know that factors 8 is around 7 rupees in the last tender, and 14 rupees it comes to around EHL, and 507 is per milligram cost of Emicizumab, and for SAFE is for factor 9. So if you talk of factor 9, we have plasmid factor 9, that's 14 rupees per unit. And if you talk of EHL factor 9, that is recombinant, that is 75 rupees per unit. And if you talk of ABCC or FIBA, it is around 23,000 per 500 IU. And if you talk of factor 7, it is around 40,000 per milligram. So if you input this data, you will get the budgeting allocation in different. Now, if you have only 3 crore funding, you have to divide how much patients and how much you want to give. You can tinker with this, data. Say, for example, you want to reduce from here 40, and you increase 10 to 50. So the patient will be the same, 100. So the budget allocation will change. So what we have done.
It is in the publication phase. So we have equated that if you have 7 treated bleeds of inhibitor positive patients treated with 100 IU per kg of APCC in a year, or 3 treated bleeds with factor 7A in a year. So that equates to cost equivalence with emicizumab. So that is how you can use this equation for your cost calculation. Then I would like to show you the guidelines. So this is a beautiful, flip book which has been, devised by Naresh sir over here. So I cannot speak much about this in front of the architect who has done this, whole presentation. So there have been categories which have been devised, and there are from category 1 to 4, then 6 to 8, and then we have some category 22, which is, and you will say why from 8 to 22 we jumped suddenly. So because sir has kept in between the newer molecules which will come, and we will rename them after that in terms of those factors. So you can see these are those action tables on which we can base our data in terms of how much and what to be given to a different category of patients. So you cannot equate a person who has a caregiver in terms of both mother and father, who has a caregiver in terms of, or who is residing in a location which is accessible to a hemophilia treatment center in near capacity of like 50 kilometers. But we are talking of a area which is of plains. At that time we discussed, so we have to actually divide it in terms of mountainous terrains versus plains. So plain 50 kilometers is not maybe 35-40 minutes. But in mountains, the 50 kilometers will take around 2.5 to 3 hours. So that we have to tinker with. But in terms of hemophilia related parameters, this table is given a beautiful presentation of how and where you can underscore the need of regular replacement therapy, and it proves to be cost equivalent and cost efficacious in terms of giving treatment to these hemophilia patients. So similarly, we have a separate table for non-factor therapy also, and for a non-factor subgroup you can see in action table 2B. So I can share with all of you this flip book. So I can share my presentation with Sanjeev sir, and he can share with you. There is a link to the flip book, and you can use this for your ready reckoner purposes. Okay, so this is the guidelines. This is the link to the flip book, and you can just download it and you can just see and read this book. And I believe that probably the guidelines which have been devised by the J&K, they are also based on this same, this thing. And I believe that all persons with hemophilia, I always say persons with hemophilia, and that is what we should say, they are not patients. So if you give them the right amount of factor at the right time, they will get the best possible, outcome in terms of life first. Their life will be saved, and quality of life definitely will improve. So then one of the most important things which we are in the pipeline is an AI-based learning software, wherein we are trying to put in this data from different patients all across Punjab. So probably this is being followed in some other states also. We are on the side swing because right now ICMR has launched a new portal wherein they are having the same data being done, entry being done for hemophilia, thalassemia and sickle cell. So for us it was a challenge because it is totally raw. It is not having the functionalities which we would expect. So, but our state has told us you can stop doing the entries here, you shift to that. And that is a totally obsolete, raw data, jo usme ban raha hai abhi. So this software has the capability of interpreting the data and giving you the results in terms of what patient requires what. So this is the future in terms of, probably when we are talking of AI, so AI is the future. The AI-based algorithms will guide you which patient requires what kind of factor and where you can save money and have the quality of life preserved with the patient also, and save the government exchequer also. So government will have a data-driven data analysis possible. So there is one agency, if you must be all aware, HTA. So there is an agency which is in PGI and AIIMS. So they are looking after these data in terms of both pharmacoeconomics and HEO or analysis also. And in that we had submitted to them from Punjab, and they gave us that high dose prophylaxis is not equitable with the non-factor therapy, but you can talk high dose prophylaxis is equitable with non-factor therapy, but not else. But they forgot to mention about the inhibitors. So I gave them the paper and I gave them my raw data so that they can use this and give at least the consideration to the patients with hemophilia A with inhibitors for this therapy. So with this, I thank you all, and I am sorry I have been a little fast, but probably thank you very much for listening, this patient listening. So any questions, please?
Thank you, Dr. Wan. This is a basically real challenging part of. Yeah.
Sir, I will take it, sir.
Sure, sure.
Thank you. Thank you, sir. Thank you, sir.
इधर लगेगा चेयरपर्सन को इनवाइट करना हाँ हाँ कर देना यार यस एक सेकंड हो रहा है उनको पता है ना ऑलरेडी रीमूव्ड है ना अच्छा सिस्टम देख के फिर तो ठीक है अगर ये है आप ही देते हैं आपके साथ के नाम की
Thank you, sir. I would like to thank Dr. Sanjeev sir for giving me the opportunity to give a presentation on this talk. So I'll be starting my presentation. This will be a case-based approach. So this will be an interactive session. So I'll be interacting with my junior residents, PGs. So this is the first case, the mystery of persistent headache. Master A, who is a 6-year-old male child, already known case of severe hemophilia A, diagnosed at the age of 1 year. In the past medical history, recurrent joint bleeding generally managed with factor VIII replacement at the daycare center, and there was no history of any inhibitors documented in the child. So in initial presentation, child had a fall followed by head injury. There was an initial normalcy, period of normalcy, and then after trauma, patient developed sudden onset severe headache, and this was followed by vomiting and increased lethargy. So in vitals, his heart rate was 125, BP was normal for his age, respiratory was 24 per minute, temperature was normal, and saturation was 96% on room air. In GCS, it was 8, pupils were equal but sluggishly reacting. In motor activity, there was withdrawal to pain, and patient was having right-sided weakness. So, Dr. Amit, what would be the likely possibility in this child? Okay, so is it a parenchymal bleed, subdural bleed, or subarachnoid? What type of bleed it is? In hemophilia, so the most common bleeds which we see are intraparenchymal bleed. As you can see, the patient is having, sit down, this patient is having already right-sided weakness, so it is likely to be intraparenchymal bleed because everything has happened over a period of within 24 hours. So it is likely to be intraparenchymal bleed since there is focal deficit. So our primary concern, please. So our primary concern is how to manage this A, neurological status. So do we go for imaging or do we start with factor VIII replacement? So how do we proceed? Anyone? So yes, excellent. So this patient is having IC bleed, and as you can see, GCS was 8. So he is having raised ICP, features of raised ICP. So we'll be approaching this child in two ways. We'll be addressing the raised ICP and we'll be doing factor replacement. So in IC bleed in hemophilia, we all follow traumatic brain injury guidelines which were given in 2019. So in this guidelines, can we have a pointer? So this patient is having kind of severe TBI, severe traumatic brain injury, since the GC is less than 8 or equal to 8. Okay. So whenever a child who has come to you with severe TBI, we do baseline care. So in baseline care, we maintain appropriate analgesia and sedation. We intubate the child because this is a physiological difficult airway. This is the pointer. So this is a physiologically difficult airway, so we are supposed to intubate the child. Okay, so we'll intubate the child and put him on lung protective mechanical ventilation. Then we'll ensure normothermia, and this PCO2 target will be around 35, and ensure normovolumia, which can be done by measuring CVP. Target hemoglobin more than 7 and treat coagulopathy, because this is a child who is having underlying inherited coagulopathy, that is hemophilia. And Levipil or phenytoin in case patient has seizures. There is no role of prophylactic as such prophylactic anti-epileptic in TBI nowadays in pediatrics. Although there is some evidence in adults, in pediatrics there is no evidence. So we'll be following either of the two approaches. This is the baseline care. So in first tier raised ICP management, we have only two things. One is escalation of sedation and analgesia. Second is osmotherapy. Okay. So in osmotherapy, we commonly use 3% saline, and in rare cases where there are signs of impending herniation, like patient is having pupillary inequality or patient is having hyperventilation or bradycardia, if there is extensor posturing, that is M2 or M3 response, in that case you can give boluses of mannitol also. So this is what we do in first tier ICP management. So if patient doesn't respond to first tier ICP management, we proceed to the second tier ICP management. In this, because your patient is refractory to first tier raised ICP management, so he'll be going for imaging. In this, first tier and baseline care, as I told, treat coagulopathy. So you will be starting factor here only, factor replacement here only. So you will proceed to the imaging. If there is any mass effect, you will go straight away for either decompression, cranectomy or removal of mass. If your patient is still having refractory ICP, you can start thiopentone, although it is not done in a setting, moderate hypothermia can be tried, and ventilation to achieve PCO2 of 28 to 34, and higher level of serum osmolality can be achieved up to 350, although it has various adverse effects like acute kidney injury. So this was the CT which was done in this child and showed hemorrhage with significant midline shift with contralateral hydrocephalus is also there. Okay, and as you can see, this patient is having a bleed which is of different age. समझ आ रहा है? अगर आप यहाँ देखें, this is hyperdense, this is hyperdense, this is hypodense. So a bleed in hemophilia, it will be of different age. You will be finding hypodense as well as hyperdense lesions in the brain in a child who is having hemophilia. So this is how we give factor replacement in hemophilia. This is as per World Federation Hemophilia Guidelines 2020. So in resource limited setting like us, we start with factor at we target the factor levels of 50 to 80 for 1 to 3 days, followed by maintenance of 20 to 40 for 8 to 14 days. Whereas in scenarios where there is high dose practice where the resources are not constrained, in these settings we use we target 80 to 100 of factor levels for 1 to 7 days, followed by 50 from 8 to 21 days. So this child was extubated successfully on day 7 of PICU stay and was given factor maintenance for 21 days and then discharged subsequently with some focal deficit. Coming to case 2, stridor following oropharyngeal surgery. So this is a known case of hemophilia, 15-year-old boy who underwent surgery for adenoid hyperplasia, and 30 minutes after extubation he developed stridor, and anesthesiologist attending this child encountered cannot ventilate, cannot intubate situation. So what could be the likely reason? In lab investigation, there was a drop in HV from 11 to 9. DL examination was suggestive of bulge in the posterior pharyngeal wall, and in point of care ultrasound, there was evidence of retropharyngeal hematoma with severely compromised airway. Yes, so this child had developed retropharyngeal bleed, leading to airway compromised, then cannot ventilate, cannot intubate situation. So how to prevent such scenarios? So in oromaxillary surgeries, adequate preoperative factor replacement should be done, and it is the key, and avoidance of at-risk manipulations like blocking inferior alveolar artery, it can forestall the dangerous outcome in such cases. So how do we deal with difficult airway or in situations where you are unable to ventilate the child or intubate the child? So we have a difficulty airway trolley with us. So we have arranged all the equipment depending upon the plan which you are going to follow. So this is how we tackle the airway, difficult airway. So in plan A, initially you position the child, you insert a bougie and then do direct laryngoscopic examination. If you are able to see the glottis, you will intubate the child, but you will not be wasting your time. Remember to move on if you are not making progress. So the next step in plan B will be, you will be going for supraglottic devices like LMA, and you will be taking help of fiber optic intubation. If still you fail, do not waste time. Postpone the procedure whatever you are planning. Wake the child and do bag and mask ventilation. Try to maintain the oxygenation and try to insert LMA, that is laryngeal mask airway, which is a supraglottic airway. If you still fail, this is a situation which is cannot intubate, cannot ventilate, and in this case you have to go for surgical options, that is cannula thyroidotomy, and immediately consult the ENT surgeon and get the tracheostomy done in this child. So in management, expanding hematoma despite adequate preoperative CF clotting factor replacement is common, and it requires immediate infusion up to targeting the peak factor activity of around 100% in such cases, and immediate expert ENT consultation should be sought, and anesthesiological consultation should be sought to deal with the CVCI situation, and hematoma subsequently should be removed once you have achieved the activity of around 80 to 100 by surgical intervention. So in the index case, emergency tracheostomy was done with the help of anesthesiologist and ENT surgeon, factor replacement was done, and surgical drainage of hematoma was done, and child was discharged on day 14. Coming to third case, this is the mystery of red urine. K, who is 11 years old, known case of severe hemophilia, on demand factor 8 replacement for the past bleeds. He is having history of frequent joint bleeds, but there is no evidence of inhibitors. He presents to pediatric emergency with history of red urine for past 24 hours. So we all know what are the various causes of red urine. It can be hematuria, myoglobinuria, or because of dehydration with associated exercise leading to again myoglobinuria. So in investigation, you will do urine analysis to confirm hematuria, to rule out infection, check HB to assess the anemia, renal function test to assess the baseline creatinine, electrolytes to rule out any renal compromise, and imaging to identify any evidence of renal parenchymal bleeds, stones, or structural abnormalities. So in the index case, in urine analysis, macroscopic hematuria was present. There was no cast, red cell cast, and there was no proteinuria. It was only macroscopic hematuria. In microscopic examination, numerous red cells were found, and it was negative for infection, and urine for myoglobin was negative. Hemoglobin was 11.8, slightly reduced. Creatinine was 0.6, which is normal. In USG, there was evidence of pelvic distension, suggestive of possible lower urinary tract microbleeding. In management, in initial steps, you do factor replacement, targeting factor activity of 40 to 50%. This helps in controlling the active bleed from the UTI. In supportive care, aggressive oral or IV hydration to dilute the urine and prevent clot formation in the urinary tract. Avoid NSAIDs. In case of pain, use only paracetamol. Monitor urine output to ensure adequate diuresis to avoid clot retention or obstruction, and avoid fibrinolytics, because if you give fibrinolytics in these children, there will be formation of clot. It will cause urinary obstruction leading to severe colic. In renal cases where there is urinary tract bleeding, you target factor activity of 50% for 3 to 5 days, followed by 20 to 40% for next 3 to 5 days. This is a case 4 who had bruising, too many bruising, sorry. So this patient is D, who is 4 years old male child having severe hemophilia with history of easy bruisability and 1 prior muscular bleed with no history of inhibitors. At presentation, he presented to us with rapidly growing bruising on left thigh after she bumped into corner of the table 2 days ago. So he had a bump into the table 2 days ago, then had developed bruising, which rapidly progressed and became tender to touch. It was associated with limping, and child was avoiding putting weight on leg. And there was no associated fever or other symptoms. On inspection, there was large chemotic lesion over left thigh with overlying skin being tight. On palpation, it was firm and tender, and there was no fluctuation noted. The range of motion was limited in the left leg due to pain. The primary concern for us in this child is that expanding hematoma into the intramuscular plane can cause compression of your neurovascular bundle, leading to compartment syndrome. Okay, so in this, DDs were muscular hematoma plus minus compartment syndrome. So in investigation, in this child, HB was 10.4, which is slightly low. Factor level was less than 1%. Platelets were normal. In USG, there was large intramuscular hematoma in the left thigh, measuring around 8 into 5 into 3 centimeter, with evidence of vascular compromise on Doppler. So this child had compartment syndrome. So in this child, again, factor was given at a dose of 40% activity, followed by maintenance dose every 12 hourly to sustain level to achieve the level of more than 20%. For pain and swelling, child was immobilized and was given paracetamol, and NSAIDs were avoided, and Compartment pressure monitoring was done, which was suggestive of high pressures, so surgical fasciotomy was done. And this is a modern approach for soft tissue injury in hemophilia. The acronym is POLICE. P for protection, minimize further trauma to the affected area with splint or brace, ensure adequate support to prevent additional bleeding or nerve compression. In OL, optimal loading, gradual reintroduction of movements to avoid stiffness and muscle atrophy. Collaborate with physiotherapists to determine weight bearing and mobilize exercise. I stands for ice. Use cold compression intermittently to reduce the pain, swelling in acute phase. Avoid excessive cooling to prevent vasoconstriction that might worsen the bleeding. Compression, applying gentle elastic compression to control the swelling and support the affected area. But one must be cautious. If there is compartment syndrome, do not apply extra pressure or do not even use bandages. So in the index case, we will not be doing this step. E stands for elevation of the limb above heart level to reduce the venous pressure and swelling. So this is how we treat superficial muscle, iliopsoas deep muscle bleed. Other rare life-threatening bleeding in hemophilia are GI bleeds, iliopsoas bleed, vitreous or retinal hemorrhages, pulmonary hemorrhages, and pseudotumor rupture. So summary, this is the lesson we get from these complex hemophilia cases. Thank you. Sorry, sir? Sir, yes. So it was not spontaneous bleed, sir. In this case, okay. No, I'm not sure, sir. No. There is no such literature. It is mostly perioperative only. No, spontaneous. The spontaneous bleed you can see in CNS, in paraspinal region, otherwise in airways, not in the airways. No. Yeah. Yes, it is like most of the time traumatic.
Treat every case of headache if the
Yes.
Give the factor, appropriate factor, and then set for the university. This message should be provided to each and every unit people who are looking after on that particular day in the casualty. Along with those, the casualty medical officer, he should also be trained. What happens that day? Simply, then they will, because of the rush and other things, any headache person who gives the great history, they will not say, some intelligent and grown up children, they say, sir, I am okay. I am fine. Every internal consultant or graduate, they should, because it is not always available, the registrar or the senior consultant may be there, because he may be busy with and then send this way. And the other important point, girls and women, they will be
Thank you, Dr. Sanjeev. You have covered all the possible manifestations of hemophilia, like bleed, and most important for us,
ICP.
that is the inflammation around throat, the area where we have been bleeding, where you can't directly cover it.
Yes.
So you have covered all these. Exactly. These are the possible 4 or 5 symptomatology where the patient comes, and you have a nice presentation.
Thank you, sir.
Message which I think are important. Whosoever are dealing with hemophilia, they should have if their numbers should be hemophilic patients, we should have a regular CME for hemophilic patient with them, so that they know what can happen. A. The B is that they should keep some dose of factor VIII at their own house. Whatever way we have to find out, we must give factor VIII line at the patient's house. Somebody knows how to give it. The moment they have, you see, many of these serious leaks, and these children can be saved, and the requirement of subsequent requirement of factor VIII will be much less if they give a dose right at home. Why do it may take for some person 2 hours or 4 hours, and in a place like Jammu, where we have a talent problem, may take 8 hours to shift there. By that time, we
It'll be too late.
and these patients, and the role comes of the cooperative societies, which keep in touch and have a continuous education program for hemophilic patients and for their families. Of course, this fact is very well known. Today's protective factor therapy has reduced all these
Complication.
bleeds drastically low. They don't have. In fact, their quality of life is much better than ones who are on prophylactic factor therapy. But any person can develop, and I think if they are educated, they know. And some family member knows how to inject even IV infusion if they are trained. So that makes a lot of difference. Earlier, the institution, better away. Let the patient come, then can be investigated. I think this message for preventing and serious bleeding hemophilia and these steps are very essential.
Just one line. 180 to 100% they have to give in case of emergency, but they have to be treated after 8 to 12 months. Remember that.
Yes.
Not that it's every month. Since the half
Every
life
12
is
hours.
8 to 12 months, you need to be treated. Thank you,
Yes.
sir.
Thank you, sir. Thank you. Thank you.
Now I would like to call Dr. G.S. Saini to felicitate the chairpersons.
Good afternoon, everyone. We now move on to a very significant and forward-looking segment, one that offers deep insight into the rare but important condition, the official introduction to fascinating learns from hemophilia.
Indeed, hemophilia is not just a condition. It is a journey of resilience, science, and evolving care that teaches us lessons beyond textbooks.
The session reflects a strong commitment to awareness, education, and empowerment of patients and healthcare providers. It is an honor for us to have with us today the distinguished chairpersons for the session.
We're privileged to welcome the chairpersons for the event. We have with us Dr. Rajiv Gupta, medical oncologist, and Dr. Mahesh Gupta, sir, senior pediatrician. Thank you.
We also will have with us Dr. Deepak Kumar from GMC Udhampur, who is a senior pediatrician and HOD Pediatrics. We would now hand over the mic to the respected chairpersons for the further proceedings.
इसके लगा रखे माइक ही दे दो Hello, very good evening. I hope post-lunch session is not a sleep session. In any case, I have no intention of disturbing your sleep. All of you can sleep. I like this gathering so much. I have come here a few times. I must thank the organizers and especially the most humble Sanjeev Digra that I see organizing these in big ways. But apart from that, I see an ambience in Jammu. which is indicative of the passion of the people. I don't know how to describe it. When I was thinking, I could just think of my nephew telling me something sometime back. He is in his 40s. He was born and brought up in Delhi, then he moved to outside Delhi. He says, you know, there is a difference. अरे इसकी जरूरत नहीं है मेरे को, माइक देना था. He says there is a difference. दिल्ली में, if there is a traffic signal and the light goes red, the police fellow disappears. He was there all this while, but he disappears. And in Punjab and Haryana, if the light goes off, he comes from the corner, goes to the center of the road crossing, and there he starts his job. He said, why is it so? He says, Delhi fellow is looking for you to make a mistake so that he can catch you. Punjab and Haryana is wanting to solve the problem when there is a problem. So that is the kind of ambience I saw in this meeting and the decisions that I took. My intent is to tell you, since it would be a diverse audience, are there any learnings, medical learnings? There are residents from different departments, diversity is there. In your own department, whichever department you are from, is there some message that you can take home from hemophilia? Okay. A man is known by the company that he keeps. That may not be true for the hemophilia. That may not be true for the disease. Hemophilia is an X-linked disease, but this is also X-linked. The male cotton baldness, color blindness. So the diseases are very innocuous, but hemophilia can be very disastrous. Strangely and interestingly, there are two diseases which are common. They are rare diseases. One is Duchenne's dystrophy and second is hemophilia, and both have made great inroads in the management. Both are treatable with gene therapy now. Curable as we call it. And that's a very interesting thing. The other interesting thing that one looks at from hemophilia is that it has been called as the royal disease. The British royalty and the royalty, which internalized across Europe, they had this disease amongst their families. But I don't think they have it any longer. It's a matter that you can think of because morning I was hearing this session on thalassemia, and Dr. V.P. Chaudhary was also alluded to there that for 30 years he is trying to get rid of thalassemia by simple thing. I mean, this is the only disease that you can eradicate. All of it. Just by using it. And it was not to be. Here we have seen a real example that you can do. Hemophilia is all yourself. Hemophilia is a bleeding that you heard presence with. This is for you. Oh, thank you so much. Hemophilia is a bleeding that occurs into the joints and the muscles. Right? Remember? Hemophilia bleeding occurs 80% of the time in the joints, 15% of the time in the muscles, and 2-3-4% are the ones that we heard about. These Suchit brought out 4 cases, esoteric, exotic bleeds, but they are the life-threatening, dangerous bleeds, so you should not go by the number. The point I am wanting to make is not on this. Hemophilia is said to be of 2 types. Commonly, type A, type B, from the deficiency of clotting factor 8 and clotting factor 9. They are both clubbed as hemophilia because they present the same way. There is no way to distinguish them until you do the blood test and the factor levels. But look at the irony of it. Factor 8 and factor 9 have nothing in common. 9 is a clotting factor which is part of the clotting system that is generated from the liver, that is produced in the liver. It undergoes carboxylation of the glutamate residues to get activated. Factor 8 is nowhere there. It is not synthesized the same way like 9 or any other. 9 also gets synthesized outside liver. So the endothelial cells, vascular endothelial cells, sinusoidal cells are the ones where you will find it. The factor 8 and 9 dissimilarity does not stop here. 9 we know has got a role only in clotting hemostasis. 8 has got a role which is multiple. We don't speak of it, but we will start speaking of it when we start treating hemophilia with non-pediatrics. 8 has got a role as a, like pregnant ladies, it goes up during pregnancy. You do exercise, it's a non-specific acute phase reaction. So it goes up everywhere. In fact, you are doing yoga and you will find out whether the yoga benefits these patients. We could not measure any difference, but the yoga did benefit these patients. That's another story. The point I am making is that it has a role to be played in many other diseases. We had a surgeon, Dr. Hatke, he came to me. He said, sir, can we do clotting factor 8 in our micrometastasis from breast carcinoma? I didn't know that time. We had just started. 2007, 8 we started and it came 2 years later. And then we found out that he did the thesis work also, and this also went on. There is no smoke without fire. So there has to be something. The association of thyroid diseases, we had cases of thyrotoxicosis and the factor 8 level was 200%. So these kind of things are known, and factor 8 and factor 9 may be presenting the same way, but there is learning that I get from this diversity. Factor 8 also has got a very interesting partner, that is phenylketonuria disease, the phenylketonuria factor. Now they are good friends. Good friends in the sense factor 8 cannot live without BWF. BWF cannot live without factor 8. But actually it is the BWF which is dictating the circulation and concentration of factor 8 in the blood. Many of you would know that we have used desmopressin sometimes for hemophilia, especially the hemophilia who have not been exposed to clotting factor. We don't want to give them clotting factor, lest it give us to inhibitors. There we use desmopressin. So desmopressin actually pushes out the phenylketonuria factor, and along with that the factor 8 rises. Phenylketonuria factor is much less studied, even though it is much more common. Phenylketonuria factor would be several, maybe a few hundred-folds more common than the factor 8. We have done this work, and which is in line with the theme of this year's World Hemophilia Day, that is women and girls need too. We have done this work right in the beginning in 2010. We took puberty menorrhagia and looked whether we could find out a phenylketonuria factor deficiency. And we did find a good number. If 1/3 of them bleed because of this phenylketonuria deficiency, then you can treat them and diagnose it. Now here is the crux for another learning. When you do factor phenylketonuria disease, factor 8 level, it is low. And the other way around goes. Whenever there is a factor 8 deficiency, BWF will be low. So to catch and make that diagnosis is very difficult. And very often, because as I said, phenylketonuria disease is more common. Common things remain common. So it is more likely that they will get misdiagnosed as hemophilia. And that is one of the problems in our country. We have 27,000 cases diagnosed or said to be reported to WFH on hemophilia. But we see a good number that is claim to be women, several hundred. I think many of them actually would be VWF, that is misdiagnosed as hemophilia. Hemophilia is a X-linked genetic disease. Is that a right statement or is that a wrong statement? Sir, it is a right statement. It's a genetic disease which is X-linked. Interestingly, both factor VIII deficiency and factor IX deficiency are genetically linked. Same gene, X chromosome. Now, interesting part is we have 3,700 patients registered in our clinic. 1/3 of them don't have a family history. 1/3 is not a small number. Nobody should say I don't take interest in hemophilia because my lineage never had hemophilia. 1/3 does not have a family history. It's a fact which is known all over the world. I will tell you the reason why it is not there, but let me emphasize that 1/3 is not with families. So this just shows the number. So there are two issues now. It's a rare disease. If you look at the number, this was released in October last year. 4.5 lakh patients, total patients with hemophilia of all kinds. India has 27,000, right? This is the number. And it has been said for a long, very long time that hemophilia is a very socialistic disease. So you see pediatric diseases, something is more common in poor, something is rich, something is in Bengal, something is in Assam, something is in Northeast. This disease, the world over, has the same incidence. That's why you read that figure, 1 in 5,000, 1 in 20,000 or 1 in 30,000. Very socialistic disease. You go to China, you go to America, you go to Europe, you go to India. India, you go to any of the 28 states or 8 union territories, it is same. It is same across the country. This disease is very old. I don't know how they worked it out and how these scientists like us became so dogmatic as to talk about the number with such firm conviction. I really don't know. This man is Alfonso Lorio. He is a PhD from Canada. He does not see patients, but he does statistics which may be relevant to many of you pediatricians. He wrote a paper a few times earlier, couple of years earlier, I think it was 2019. He said the number of hemophilia that National Hemophilia Federation of US and every year says is about 4 lakh cases as a issue. He took these 6 countries from the Europe and of course one from Canada. So these 6 countries, he looked at the birth registers and the hemophilia, and he worked out the incidence, the prevalence of hemophilia at birth from those birth registers, and he knew the prevalence in the adults from the immune registers. They have all their organizations, and he calculated the life expectancy, and he worked out that the number of cases is not 4 lakhs. It is more than 11 lakhs. So we are thinking that the number also we don't really know. It is there, of course, when we talk about prevalence, we must tell you that the number of cases that we treat and become good are the ones who will add to the number because their mortality has gone down. When we started in 2007-8, almost all our patients, up to 80% of our patients, were under 20 years. If we treat them and they all become 100 years, naturally the number would add up. So the prevalence would go in that number. Now comes the question, if it is such a disastrous disease, severe hemophilia used to have a lifespan of 7-8 years and then 15 years for 500 years. Why is it thriving? These are the persons who will not even be able to reproduce. The disease should die away. And there is a very interesting interesting theory put forward by this man called John Haldane, Sanderson Haldane, JBS Haldane. JBS Haldane was an Irishman who came to India before independence as the director of Indian Statistical Institute in Calcutta. And he stayed there. He never went back. In fact, he stayed there and he used to love Indians. He used to love Indian food. He became an Indian. He actually got the passport also later on, citizenship I mean. And he became a vegetarian. He's fond of yoga also. In any case, his thinking had started much before he converted. And he said there is a good reason why these bad genes thrive in the society. They should die away, but they are not dying away. So this is a little complex thing, Hardy-Weinberg ratio. If you look at it, we all understand the alleles, AA, capital A, small a, homozygous. These are the genotypes. So AA would be both dominant and capital A, small a, right? And the simple A and small a would be the genes. So he says if you look at the prevalence of genes and genotypes, it is not difficult to do it. Take it from me when you are doing this work and you are going to start a genetic lab. I hope somebody who is starting the genetic lab is here. Gene clinic. Who is you starting? So it is very easy to do it. So what it says is the prevalence of a gene stays in a common fashion. It stays the same unless there are disturbing circumstances to change it. And in hemophilia, there are few disturbing stances which show up in 30% of the severe hemophilia who will not thrive, who will not make it, whose sustainability is difficult. And that is the reason why 30% new gene mutations take place to maintain the equilibrium. Right? Maybe I can give a thought for you guys, probably the younger ones. If it is a mutation, we get mutations and these cancers are also associated with mutations. So many mutations we talk about. How is it getting transmitted? Cancer mutation is a acquired somatic mutation. It does not get transmitted. So these mutations that are occurring actually are germline mutations. Yes? And the germline mutation also has actually occurred one generation earlier and then he got it and then it passed on. So it's a very fascinating thing if you look at these 1/3 ratio and the prevalence and the incidence. When we took over in 2007-8, the management of hemophilia, they were so bad. If they come to your clinic, somebody is coming in a wheelchair, somebody is coming with crutches, somebody is coming in a lap. These were all small babies. Then we did 2011, we did a first international study on epidemiology of hemophilia in 6 developing countries, India, Algeria, Morocco, Sultanate of Oman and South Africa. And we found the same scenario everywhere. And that is what you look at also. The annual bleed rate was 25. That means almost every 2 weeks they would bleed. I'm talking about global. December and the nearest access to the hemophilia was 80 kilometers away. And you heard from Dr. Varun call 80 kilometers can mean in terms of hours a long time. So there are some countries, if you ask them how far is this place, they don't tell you in kilometers. They say it is 10 minutes away or it is 10 hours away. So I think this is how we should also work on. And I'll leave this story of the first country. But we faced a problem in 2007-8. Health is a state subject. Hemophilia was being treated by the government in Delhi only. Everybody started moving to Delhi. In fact, they started taking it on rent, the property, and they started buying just in case, whether there was a talk. I was pressurized that you should not give treatment to anybody from outside Delhi. This comes from the parties, political parties. I said, you can order it. I can't order it. I have to treat the patient wherever he comes from. I can't say no. In fact, I had a patient, sir, who came from Afghanistan. हम बोला आप कहाँ से आ गए यहाँ पे? बोला सर बहुत सुना है हमारा बच्चे को हीमोफीलिया है. So what do we do? I said, okay, we'll treat him. I gave it, but I didn't want to take a chance. So I told the MS, I said, we have a patient who has come from Afghanistan. He says, Naresh, what do you think we should do? I said, I think we should treat him. He said, no, but that will be a problem, He knew that it is an expensive treatment. He had to pay the money. I said, see, Siddharth, show me the OPD card. We had our own OPD card, by the way, but we saw the hospital card. Does it have a column of which country he comes from? There is no column. So we had patients coming from everywhere, and that is the reason why we undertook this advocacy, capacity building, and it spread to other states also. But this, traffic that I want to show you is more important. We used to have a patient coming from Nagaland. He's the son of a pharmacist there. We said we are going around and starting hemophilia clinics. We came to, sir, in Jammu also, we came to Srinagar also. We had some pictures last time, somebody pointed out. So we said we'll start in Nagaland also. He says, there are no takers. So I bring my son here in the train. I land here, I take the treatment, next day I take the train and go back. What does it mean to us? It meant two things to us that time. One is, even if health is a state subject, the money for treatment is going from the Consolidated Fund of India. If you don't treat this person here, he is suffering, his family is suffering, everybody is suffering. But actually, so we went to Rajghat on one of these hemophilia days, and we launched in 2011, 2014. One country, one treatment. And this we've been trying to push. So that was one of the reasons, but this also got a help. Okay, this also got a help. You see this joint very frequently, but this joint is not simple bleed. I'm back to actually Nagaland story, one country, one treatment, but I have diversified into this to make my point. The joint that you see in hemophilia has got a blood in it. Blood can occur in the joints in many other conditions. Somebody is a sports person, he plays soccer, you get this. Cycle injuries, you get it. The bleeding that rheumatoid arthritis also you get it. Malignancies also you get it. The bleeding that occurs in hemophilia joint outside. You look at this, there is blood inside the eye. I can see on that monitor. This was a young man who was waiting for his turn at the ATM. इतना ही गर्मी था जैसे आपके यहाँ पे है. So ATM होता है ना, it's not a fan, but you can certainly have the, pleasure that I am having few wind of flowing air. So he was doing like that. It touched his eyelashes. And never heard of it, never read it. And the point is, whether it is you call it spontaneous or whether you call it mild trauma, I think I'll call it mild trauma, but it is something that was never heard of. What do? We gave him 100%, we gave him 100% correction. 1 day, 2 days, 0. He did not have reading, he could not perceive light, perception of light was 0. And we didn't know what to do. So the second day, we decided we would open it up. So we convinced our ophthalmologist, we said what you do is you irrigate it with normal saline. Let this blood be washed out. Interestingly, there is a, this question also comes, when they bleed into the knee joint, which is a common joint, should we aspirate them? Will they make it better? The world says, no, you should not aspirate, you can introduce infection, you can do all those kind of things. But if I look at the science, the pathophysiology that is going on, is it possible that if you aspirate them or irrigate them, the pathological molecules that come in, whether it's iron, transferrin, whatever comes in there, they'll all be washed out and the ongoing hyperplasia will be reduced? I don't know. But we didn't know. But in any case, we said in this case, we will go ahead and do the irrigation. They did the irrigation. The man improved the same day. He's 12 by 60 today, and it is about 10 years story. He's 12 by 60, he can see it, he's very happy, he runs his shop. Did we do something different? Did we do something wrong? Whenever you are doing something which is with the good intention for the patient, it is always right. And a couple of years back, in fact, there is a Spanish group, they are promoting whether we should actually aspirate the hematomas that occur. And they have probably a good reason. This was a poor man from Bihar who had a pseudotumor, as I was talking about. Pseudotumor is something that again you see very uniquely in hemophilia. You don't see in other bleeding disorders, you don't see in other bleeds also. He had a pseudotumor which involved his thigh, it was 30-40 kgs. We got it out, his femur had become pencil thin. I used to wonder, how is he walking when he came? We gave him support, but we couldn't do much because these are very bad ones, and we used to see many pseudotumors, large number of pseudotumors. But now we don't see so many. Okay, so let me know, sir, whenever, Sani sir, whenever there is time. Continue. So we also found something very interesting. Boys don't have anemia, so much anemia. We didn't see so much. The bleeding that occurs internally should not cause anemia because the iron will be recycled. Only external bleeding should cause it, which is not very common in hemophilia. But what we found as comorbid conditions, anemia was there in 50 to 60%. Mind you, these are boys. So not less than 50 to 60% had moderate degree of anemia. So something was wrong there. Hematuria, whenever it comes, we had a case also, we would think it is stone. We would not think of hemophilia as the cause, as the first cause. And the reason being, North India is on what we call the stone belt. North India goes up to Iran, and we see these stones very common. In any case, tuberculosis also is common for that, and tuberculosis also is common as a abscess, which can mimic psoas bleed in cases of hemophilia, and of course, hydrocephalus. Dr. Sanjeev probably is getting... okay. more interesting. Hemophilia was treated with factors, and it was treated with factors until the 1980s, late 80s and early 90s, and even now. It brought in three bad things. One bad thing, it brought in all transfusion transmitted infections. Hepatitis B, hepatitis C. Hepatitis B, we have a vaccine, and it is a rule that all our patients are given vaccination against hepatitis B. Very, very big rule. And the second provision in that rule is you would not want to give it, hepatitis B vaccine. All of you have taken hepatitis B vaccine? Anybody who does not take hepatitis B vaccine should not visit the hospital. It is very dangerous. So if you have this hepatitis B vaccine, it has to be given deep intramuscular as per the standard textbooks. We did a project before we started giving this, and its subcutaneous route was 100% seroconversion, 100% seroprotection. So we give subcutaneous route to all our hemophilias. This is a Holocaust picture where movie also was made, and this is from US, where they are talking about the HIV and the hepatitis. So transfusion transmitted infections, and HIV became more important because HIV was recognized as a disease because of hemophilia. Had hemophilia not been there, this disease would have gone out as gay-related immunodeficiency syndrome. If you remember it, early 90s there was a syndrome which Americans had invented. They called it gay-related immunodeficiency syndrome because HIV was thought to be a disease of the gays. And these guys said, no, we are not gays, and we are taking this. And that is what I don't think it's a good thing. I don't even think that treatment should thrive. The reason why clotting factor therapy was thriving was we did not have a better alternative. Otherwise, 30% inhibitor therapy, which is more expensive to treat, very tedious for doctors, patients, and even then the results are... So we have these drugs now that take care of the inhibitor treatments also. But the point is, we should not overlook these outcomes of the hemophilia that we are seeing. Okay? So the time has come, and I would rewind it up in another couple of lines, sir, if you don't permit.
Sir, please, but we wish to hear for many hours. It's interesting, but...
No, I'll just cut it. So, another fascinating part of hemophilia was we had recombinant factor 8 for hemophilia A. You give any amount of it, whatever is permissible, but we could not make it disease-free or bleed-free. There was a limitation. And that limitation we'll not discuss, but there was a limitation, but which led to the development of extended half-life, because you don't want to inject every alternate day. You could do it every once in 10 days, and the non-factor therapy. So I'll just say a word on non-factor therapy. This is the extended half-life. You do the pegylation. The non-factor therapy is very interesting. You have the monoclonal antibodies, which takes the antigen, takes it to the natural killer cells. In bispecific antibody, he's speaking on this. Okay, so I will not take on this. So emicizumab is an antibody which came in with a big advantage. Antibodies can be given subcutaneous, you don't need to give intravenous. And you can give it once in a month, right? Finally, there was a very interesting article. Where is it gone? There is a very interesting article which was published by my colleague. I leave it in 2007 or 8, where he did what is called severe hemophilia don't bleed the same way. Severe hemophilia don't bleed some will bleed less, some will bleed more. So he looked for other factors, what is the role? And he found that the anticoagulant factors in less bleeders were less. And that is what led to this, what we call the rebalancing therapy, where you take the anticoagulants and the procoagulants and create a rebalance. So I am sorry to have overshot, but if there is a quick comment from anywhere, I can take if the chair permits. Otherwise, thank you for patient listening or stunned listening.
Thank you, Dr. Dinesh. Very exhaustive, but very fascinating talk that you had. The crux of the message about the papers is that one mission, one treatment of the body. And we must always stick to the one of the three things, that is time, transport, and pay. So this is how the evolving concept of regional centers for hemophilia is getting its place and view. Thank you very much once again.
Last point, as sir has mentioned about genetic mutation, hereditary mutation in oncology, 5 to 10% cancers are related to genetic mutations. Like it can be BRCA mutation, breast ovarian or FAP. But I think this is a natural process of flushing out the weaker ones. I was going through one documentary. One bird mother was pulling out its one of the weakest, I should say, bird out of the nest, so that rest of can survive. But now we have evolved species, possibly we are carrying out. It may be a natural process to purge out those who are genetically weak, offspring would be weak, and so there's Darwin's theory of getting the strongest to survive and rest to perish.
Where we have seen the patient's adherence is almost down to like 8%. And if this is continued to a patient who had orthopedic and it has started improving. Suppose this is where this shot by whatever reason, and there is a delay of 1 or 2 months. Will that have any complicating effect? Yeah.
So I didn't show that slide, but emicizumab, but if you draw the blood levels, so the blood levels are done either because they are on a weekly dose or a 2-weekly dose or a monthly dose. The best efficacy that you see is weekly dose, but most convenient is monthly dose. So it depends on which protocol is he taking. If the person is taking a weekly dose and if he misses a couple of doses, I think that will still go on. He has a reasonably good chance to go breakthrough bleed and upper like I showed in the so if he is taking once in a month and he misses his next month, the chances are that for the next month his chances of bleed still are low. It's not at 0, but it is still low. At subsequent months he would bleed. We had a child came from Noida, and he was given because we were getting some emicizumab, so he used to get it. And when they did not take for 2 months, third month he had a rest bleed, and it developed into a very severe problem. It's like a 15-year-old, 13-year-old diabetes. The bones have gone up. So it can be disastrous, but the chances are smaller than the
You see what happens even in hemophilia. Earlier I was thinking on treatment. You have a patient who will develop treatment, and the other will develop once a year, once in 3 years, and factor level being same and top. The question what happens you cannot predict when a hemophilic will develop a lead, whether it is on therapy or off therapy, and on therapy it will be a breakthrough lead. When it is off therapy, then you say it is a trauma of the
Thank you so much, sir. Now I request the chairpersons to kindly felicitate. I request the chairpersons to kindly felicitate the speaker. I now request Dr. Sanjeev sir and Dr. Mohammad Razak to kindly felicitate the chairpersons.
सब बच्चों की हाइट ठीक है
ठीक है
आप कुछ नहीं चलो
अच्छा ये अप्रोच टू अ मीडियम
प्रेजेंटेशन किसकी
वो नहीं होता मुझे लगता है हम बुला लेते हैं
Moving ahead with our next session, which is approach to a bleeding child.
Bleeding disorders in children can be complex, time-sensitive, and often present diagnostic challenges, making it critical for clinicians to have a structured and evidence-based approach.
Today, we are privileged to have with us two outstanding clinicians and experts in pediatrics and hematology, each bringing a wealth of experience from both the bedside and the lab.
First up, we have Dr. Ghanshyam Saini, former Head of Department Pediatrics, GMC Jammu.
Next up, we have Dr. Fayaz Wani, who is the Head of Department Medicine, GMC Jammu.
Together, they will guide us through a comprehensive approach to evaluating and managing a bleeding child, from history taking and examination to lab workup and therapeutic interventions. Up to you, sir.
We also have Dr. Deepthi Mahajan from the Department of Pathology, GMC Jammu.
lot of work in the hemophilia. It is because of his effort that we are getting so little drugs. In one of the conferences, he showed us his persons with hemophilia playing cricket.
ये चलता है
ये नीचे वाले से ना
Over to you.
Pointer. Thank you.
स्क्रीन से मिलेगी ऊपर वाले से वापस
Thank you for the kind introduction. Actually, I would have loved to have many residents in the audience. I mean, the people, the surgical, the medical, who are running the OPDs and the emergencies. The topic is purely, designed for those people. But unfortunately, I see, most of the faculty and very less of residents. Because this is the thing Dr. Sanjeev said in his, lecture in the first, in the inaugural ceremony, that, he was surprised to have the more people of Jammu and Udhampur in here. And he was surprised that there was no there. So the ultimate problem is the diagnosis. So what we have diagnosed is only the tip of the iceberg. The India having a population of 1.4, 1.5 billion, and we expect if of 1/10,000 or 1/20,000, we expect 1,50,000 persons with hemophilia and bleeding disorders. But we have just diagnosed 27,000 to 30,000. So that contributes just about 20% of the total population, and our 80% of the people who are undiagnosed, only the dilemma is about the diagnosis. So because we don't know how to approach a person who comes with a bleeding in your OPD, in your emergency, or whenever you are managing the things. So that is why this topic is very important and is a very basic thing for the, which most of the thing, I don't know whether GMC Srinagarite, Dr. Dipti might be, correcting me. You are doing PTA, PTT. So many of the medical colleges in, India are now doing still PTA, PTT. So, and even our surgeons, when they write for the, they have to go for the PAC, pre-anesthetic checkup, the anesthetist, they go for the PAC, and the surgeon writes, they write advice PT INR. Why INR? The patient is not on the anticoagulant drugs. Why you are asking INR? INR is for the monitoring. The concept is so low in our doctor community. We cannot blame other people. So that is the reason we should have some knowledge. That is why the audience, the residents are very less. I don't know why. This topic would have been very loving for them, and this is the reason. Our hemophilia journey started in 2012 in Kashmir. We had just 70 people who had registered there, right? So ultimately, we were pulling them because of the pill, and the government gave the funding, and the people came up with the registrations. Till 2017, we had just 100 people. But in 2017, we celebrated a hemophilia day, and when the importance of the lab was taken into the confidence, so this is this, and when we set up the coagulation lab in 2017. And in 2000, you will not believe, in 2017 to till date, we have 437 people who are diagnosed. It is only the lab which is giving us the diagnosis, because this is the era of evidence-based medicine. You cannot, today is the evidence. You have the evidence that the patient has low hemoglobin, anemia. You ask him a CBC. You cannot give him straight away iron therapy. You cannot give him folic acid or vitamin B12. No, not at all. Unless you have a CBC, you have a PBS, you have a B12 folic acid level, iron profile, and every thing is there. Then you can decide whether the patient is having iron deficiency or folic acid or anemia of chronic disease. So this is the evidence based. Similarly, in case of the bleeding disorders, you should have the evidence, and then you can treat. So that is the thing. 2017 to 2025, we have this. So this has been discussed about hemophilia is an X-linked autosomal recessive genetic bleeding disorder, and prevalence has been discussed all. This I will skip, and this is the 5 years back slide which I have said that in India only 20% of the people are diagnosed. In Kashmir, if you have a 9 million population, we will expect 900 people with hemophilia, and out of 900 we have diagnosed 437 thanks to the coagulation lab. Because in every month we are registering 2 or 3 patients. Every month the things are going increasing. Because but the thing is that lab is not only thing which I am just focusing on this. Don't trade the test. You are the clinicians. Don't ever trade the test. my biggest test is history. I always say in every form, I say that don't treat the test, always have a good clinical history. We had a previous in medicine Hutchinson's manual of taking history and examination, and that handles true today because many of the things you are rush in OPD, you just advise top to head this bottom these investigations and then come with the investigation, but don't skip history. That is the sincere advice. So this is the algorithm for going for the bleeding disorders. I will just come up on the last bleeding. So history is the biggest test. So firstly, a child comes to you with a bleeding, so you have to see whether he is a bleeder or not. So you have to just confirm that. If he is a bleeder, you have to then confirm whether it is a severe or is a mild. If it is a severe or mild, then you have to go for the third question, whether it is a primary or secondary, because there are two hemostatic mechanisms in our body. And then family history, whether it is inherited or acquired, by the asking family history and all pedigree of those things. So you can come with of those lists. So to identify bleeder, one needs to know the frequency of bleeding, history of any invasive surgery without transfusion, spontaneous bleed with no provocation, and hospital visits and how did it stop, and all those things in the OPD you can ask about those things. So this is the ISTH BAT score. So in history, you have to, it is based in the internet available. ISTH, International Society of Thrombosis and Hemostasis, they have given the bleeding assessment tool. So you should know the bleeding assessment tool. There are different, there are 14 variables in it. In every variable, there are scoring point from 0 to 4. You have a 56 score, and in different types of, so these are questionnaire on this thing, you can ask these things. So then ultimately, out of 56 points, in males and females, it should, in males it should be 0 to 3, and in females to 0 to 5, and in children it should be 0 to 2. So if the BAT is less than 2 in your children, so unlikely the child is suffering from the bleeding disorder. But you should know the BAT score, and you should have the patience for asking the different questionnaire to the people who are coming to your OPD with the bleeding disorders. So that is very important. So this is the thing I want to say, that abnormal coagulation parameter has no major diagnostic value if the history is not supported. Sometimes what happens, because the coagulation testing is very sensitive. It is not like biochemistry, it is not like CBC, and it is not like other routine baseline investigations. It is a different investigation which needs a meticulous phlebotomist and which needs a very trained phlebotomist to know how to collect the sample, how to transport it, how to centrifuge it, and I will go by that. That is the reason, because there is so many discrepancy in the labs. You are going for the PT-APT, one lab is giving one result, another is giving another result. Then you question the lab and the pathologist. No, he doesn't know. I mean, the same sample we are sending here and there are so much disparity. So there are a lot of pre-analytical errors. So before it reaches to the analysis part, there are 70 to 80% chances of pre-analytic errors in everywhere in every lab, but in coagulation it is more because of many checks and balances in collecting the sample. So that is why if your clinical history doesn't support this BAT score is less than 2, even if lab gives PT, APTT highly deranged, don't accept. Don't accept, repeat the sample, go for the good lab and cross-check the investigation. So in bleeds, I can divide it into two parts. One is superficial bleed and second is deep bleed. So just maintain that in the clinical sense, superficial bleeds are all mucocutaneous bleeds. You have bruises, right? So in the under skin and all those, they are superficial bleeds. So always when there is a superficial bleed, always suspect there is a defect in platelet or von Willebrand. These are the two things to mention, right? And if the bleed is deep, I mean in the joints, in the muscle, in the life-threatening bleeds which have been discussed, so always think that deep bleeds are only because of the coagulation cascade defect. I mean the clotting factor deficiencies, clotting factor defects. So these two things you can categorize, superficial and deep. In the history and examination, you can just segregate which investigation to write. The best physician is who knows what to prescribe, which investigation to prescribe. It's not. It is very easy to prescribe, from baseline to special to super special investigations. It is very easy to write down all the investigations. But it is The best physician and the best practitioners who either there will be a fibrinogen deficiency or is a factor 13 deficiency, unless proved otherwise. So these are some different types of scenarios. So where comes the role of laboratory? So because as having said already that the evidence-based medicine, the best, if you have a correct diagnosis, you can manage easily the things within 2 to 4 hours. You should not reach beyond 4 hours because all you know within 2 to 4 hours. You should not reach beyond 4 hours because all you know the coagulation and all those, they are proteins. They are labile. So if you are not transporting them in a proper way, in a proper temperature, they will get disintegrated. Even if the patient has good factor assay level, when it's reached to the lab, the factor assay has gone and the lab will give the wrong result. So these are the very important precautions you have to take while taking the sample, particularly for the assessment of the bleeding disorder. You don't have to shake, you don't have to make the frothing of the blood, and the important thing is the ratio, trisodium citrate ratio. I mean, most of our people doesn't know. Even we receive in our lab, for the coagulogram in EDT. Sometimes you get in a red top. I mean, I'm surprised. So this is the thing that I would have loved to have the phlebotomists and other people here to know that what is the actual cause. So it is a sodium citrate tube which you have to maintain a ratio of blood and anticoagulant as 9:1. So then there comes a challenge. In a citrate tube also comes a challenge. Sometimes the nurse fills the whole tube. There is a particular mark on that. Just you have to fill the blood up to that mark because the anticoagulant is up to that ratio. If you go overfilling, then the citrate will not work. I mean, the plasma will be more and the anticoagulant will not suffice for that anticoagulant, right? And similarly, if you underfill, that will also give a false result. So those things also are very important to monitor: overfilling, underfilling. And sometimes then there is a hematocrit challenge. Sometimes your hematocrit is more than 55. So plasma is very less, in hematocrit is more. And the citrate is for the normal, 50 to 55 hematocrit. If 55 is more, 55 to 65 is there, so you always throw out 0.1% of the sodium citrate. If it is more than 65, then you have to apply for the formula to correct the blood volume with the citrate. So these are the very important nitty-gritty things which very much impact on your coagulation. These studies. These are very important. So then these are the baseline investigation for the coagulation. Platelet count, do PT, APTT, right? And do thrombin time and fibrinogen. These are the basic tests which we need to do. And then if I have given this is a coagulation cascade, you know that in the superficial bleed, if the superficial bleed is this, ask for the PT. Yes, if there is superficial bleed, go for the BT. Otherwise, BT, CT is an obsolete test. Nowadays, don't go for the invasive surgeries and others. BT and CT is always done, only BT. BT is done for the superficial bleed. When you suspect there is a problem in platelets or there is a problem in von Willebrand, then ask for the BT. If it is a deep bleed, then your platelets BT is not going to do. There is no business to ask for the BT. Similarly, if now there is a deep bleed, you ask for the PT, APTT, and you ask for the thrombin time, and you ask for the this fibrinogen level. So factor 1, factor 2, and this PT and APTT, because of knowing on the coagulation cascade. So if the platelet count is less superficial bleed, so it will give a thrombocytopenia, that will lead also to bleed. And if platelets are normal, but still you are giving a superficial bleed. So if platelet count is normal, but you have a superficial bleed still, so always suspect functional disease. There is a qualitative, because platelets have a quantitative defect and qualitative defect. So if you have there is a aggregation defect or there is a storage pool defect, so there are so many these GT and all those findings are there. So if the platelet count is normal, still you have a superficial bleed, then suspect of platelet functional qualitative defects. So the best method for bleeding time is modified EVs method, which most of the things are not being done. Even in our practice, they are doing the bleeding time, just pricking on the finger and just squeezing and then seeing how much time it will stop. That is an obsolete method. You have to ask for the volar aspect. You have to give the 2 pricks, 1 and 2 here on bare area where there is no hair, and then with Wattmann's filter paper, after every 30 seconds you have to push the stopwatch and just see when the bleeding stops. So that is, and you have to keep a 45 mmHg blood pressure cuff continuously kept on the arm, and then check the bleeding. So that is the bleeding time. Bleeding time is up to 8 minutes. If more than 8 minutes you suspect, then you can suspect there is a platelet defect or there is a von Willebrand defect. So these are the things which are used here. So this is the modified EVs method. I mean, you can suspect, if you don't have the platelet aggregometry, you have to know whether it is a functional defect. It's a very basic test. I mean, you have to do the first prick, you do the normally you do the platelet count. For example, if it is 1,50,000. Then after 1 minute, you take the bleeding side, do the platelet count. Do the platelet count after 1 minute. So what would you expect platelet count? After 1 minute, it should be increased or decreased? Any reason? I mean, the first prick, you have taken the platelet count, right? So that is a normal platelet count. 1,50,000 is okay. Now after 1 minute, I am taking this, the point is bleeding, I am taking the platelet count. What should be the platelet count? Normally, by your physiology. It will increase or decrease? No, it should decrease because they are utilized in clumping. They are utilized in clumping for making the clot. So at least there should be a 70% should be used if they are functional. If they are less than 10, you can suspect von Willebrand. If they are 10 to 25, you can suspect GT. It's a simple test by which you can just quantify the platelet functional disorder by modified EVs method. So then you can go for the specialized tests, antigen activity and assays and everything, multiple and collagen binding assays. So now there is a question. Now you have done these are superficial bleed. Now we are going for the deep bleeds, which we are discussing about the intracranial, muscle, joint and every bleed. Hemophilia comes there, and now you have to see. I mean, it's not diagnosed. Now you have to diagnose. So you have asked a question. You have asked the prescription for given a lab PT, APTT for 2 basic tests. So now what happens in the first case? PT is prolonged and APTT is normal. So by the coagulation cascade, which factors should be deficient? Factor 7. So if normal, then there is a normal PT and abnormal APTT. Which factor? So it should be factor 8 or factor 10 or 11 or 12. So they are there. If both are prolonged, so they are common pathway. So simple. If it is PT, it is extrinsic pathway. If APTT is intrinsic pathway. If both, then common pathway. Common pathway vectors. So you have to just that idea. After this, you have to go for the mixing studies, which is very easy. I mean, if a lab is doing PT, APTT, you have a pooled non-plasma, you can do, you have the control and all those, you can do that. Then PT is increased, and this is, as you said, this is factor 7 deficiency. So this is the algorithm you can see. Now you can, you don't have to have the highest reagents for them. You have 2 things, normal serum and adsorbed serum. Normal serum, simply you are taking the sample, you made it to clot, and the serum is there. It contains all factors, I mean 9. It contains 9, it contains 11, 10 and 12. And it is called normal serum. Then if you add the blood drawn to aluminum hydroxide, it becomes adsorbed plasma. What happens is that factor 8 is very labile, and factor 8 is preserved in adsorbed serum. So now you know that adsorbed serum has factor 8 and normal serum has factor 9. Rest are common. And now you can do the mixing studies. I mean, now the thing is that your APTT is prolonged. Now you are adding normal serum. If it is not correcting by normal serum, it is correcting by adsorbed serum. So it means there is factor 8 deficiency. So because APTT, if it is there, for example, 60 seconds, then you are adding 50% of patient sample, 50% of the normal control, where you have, the adsorbed serum. So adsorbed serum has factor 8, it corrects the APTT, that means it is factor 8. It gives an indirect evidence that you have factor 8 deficiency. Similarly, if it gets corrected by the normal serum, then you have factor 9 deficiency. So this is the algorithm by which you can just, by mixing studies, you can diagnose factor 8, factor 9 and factor 5 and other deficiencies. And even if they are not corrected by, by both normal serum as well as the adsorbed serum, you can then go for the thrombin time, and by thrombin time is prolonged, then you have factor 2 deficiency or hypoparathyroidism or dysproteinemia, or even you can suspect, if they are not corrected with this, you can suspect inhibitors also. So these are algorithms by you can mixing studies by which you can just diagnose these things. So this is a case 1. You can see that 14-year male with large swelling at the back of the thigh with discoloration, 2 years symptomatic, and knee joint swelling is now walks with limp. Family history, maternal uncle died of hemorrhage of RTA, and his mother, younger sister, son also has. So that means there is a maternal history. I mean maternal uncles and all those, so autosomal recessive is like that. So then the lab tests come, BT is normal, platelets are normal, and PT is 12. Because liver is the ultimate coagulation factor synthesis. Even liver damage can lead to the most of the coagulopathies. So you have to keep also that in mind. Not always every bleeding is a hemophilia or any other bleeding disorder. Similarly, case 3, you have prolonged bleeding, you have epistaxis, they have superficial bleed, consensual marriage, and you can see bleeding time is more, rest, platelets, PT, APTT, everything is normal. So it can be, BT is more superficial, so it can be platelet disorder or it can be von Willebrand. So, but platelet disorder is not there because platelets are okay. It can be a platelet functional disorder, but it can be that also and it can be von Willebrand also, because von Willebrand is a part of superficial bleed. Similarly, has a large hematoma, again umbilical system bleed, which I said that umbilical system bleed is a particular thing for the hypofibronemia and factor 13 deficiency. If you have the history, and you can have these all things, you again BT is more, and you can have the factor 13 or fibrinogen deficiency, because fibrinogen levels are very low. This is again same case. So this is the last case, and continuous bleeding gums, bruising. Time is more, and it can be related sort of von Willebrand. So these are the basic tests you have to ask about this thing. Firstly, CBC, PBF, platelet count, PT, APTT, right? So these things you have to keep in your mind while seeing a child in your OPD. These things you have to mention. Then after getting the interpretation, but you should have a good coagulation lab, and you should have also take the cognizance that the phlebotomist should take all those precautions which I have said, that he should not go beyond those things. He should not violate those SOPs of collecting the sample and transporting it and centrifuging and putting into the lab. So all those criteria, if they are met, you will get the result and you will get the child diagnosis of certain bleeding disorders. So those are the how very simple. And then there is coming a challenge of inhibitors. Inhibitor is nothing else, is an antibody. You are pushing a protein in your body. It can be a factor, so barring non-factor therapy. So factors are proteins. Our body is a defense system, have internal defense system. Whenever any protein comes to our body, our internal defense system fights back, is a foreign thing, and makes an antibody against it. So that antibody against the factor dilutes, neutralizes it, and that is called inhibitor. So that inhibitor is very important. While your patients are on regular replacement therapy or on-demand therapy on the factors which are plasma derived or which are 3rd generation or 4th generation factors. So when to check the inhibitors, this you should know. A child newly diagnosed as pediatric small child with hemophilia, he comes to your OPD, now you have started the regular replacement therapy. So you should know expose him for this thing. For up to 20 exposures. That means up to 20 exposures, 4 times. 4 times you have to check the inhibitor screen. And then up to 50 exposures, every 10 exposures. Means 3 times up to 50. Right? So then after 50 to 150 exposures, exposure means injections, 150. 50 to 150 exposures, twice yearly. And after 150, every year. And always before surgery. Before surgery, whenever he is going for any hemophilia related surgery or non-hemophilia related surgery, always check inhibitor status or inhibitor screen. So maybe the things are not yet available for the inhibitor assay. We have all the things available at our lab, but I think that Dr. Dipti will take this message they will build a good coagulation lab in collaboration with Dr. Fayaz and Dr. Digra, and they will make a good lab, and I assure you that our clinicians will never face any issue, and they will also, you will get more, the things that Dr. Dingra said, that we have very much population of Jammu and Udhampur. More people will be diagnosed when you have a good coagulation lab for that. So this is the inhibitor assay and screening, and at least inhibitor screen you can do, because it is basically an APTT based test. Very simple test. You have to do a test of the patient and the control. Control means all the factors are there. Then you have to put it in a water bath. You need just a digital water bath. If you have an automated coagulometer, I think you have got at that. So that thing you have to get, and then you have to mix 50%. 50% patient plasma, 50% control. Control means all the clotting factors are there. And do the APTT. For example, normal control APTT is 30 seconds. Patient's APTT is, for example, 60 seconds. This is the range, right? So now I took the 50% of the plasma of the patient, 50 of the control. So I mix it and do again the APTT. So what should you expect APTT? It should come down or it should move more? It should come down, because the normal factors are, they are just correcting the things, and APTT will be corrected. And how much it's corrected, that you have to know. For example, if it was 60, so it has come down to 40. That means it has done a correction. So then after correction, you have to incubate it for 1 hour and 2 hours. You have to take the reading after every 1 hour, after 2, because most of the inhibitors, antibodies are dormant. So they get activated after 1 or 2 hours when you put them in the incubation, at the body temperature. So they get activated. So after, if you get a fresh mix, APTT is 40, and now you are doing after 2 hours APTT, surprisingly you are seeing it now, it has increased. It has gone to 50. So the difference is 10 seconds. So whenever there is a difference between fresh mix APTT and incubated mix APTT, more than 8 seconds, always remember this thing. If there is for the lab people, if there is a more than 8 second APTT difference between a fresh mix and incubated mix, that means inhibitor is present. So then you can go for the inhibitor assay. So then you can recommend for the inhibitor assay, and your job is done. So I think all things are been discussed. I will not take much time, and thank you, chairpersons, for the things. If you have any questions, you can take this.
Actually, presentation very practical, and I think my resident should look into these things before sending the investigation, so that we get the correct interpretation.
Excellent presentation, Dr. Lal. Giving these children presented with the emergency room is not an uncommon thing, and was anything as simple as those taking which our PhD colleagues can pick up easily, or it may be a bleeding or a clotting disorder or leukemia. So, as you rightly said, history is very important, systematic approach is very important. History, examination, and then going for the investigations in a systematic manner, that will probably lead us to the final diagnosis. Thank you very much.
Thank you.
I just want to say it was a pleasure to chair a session where a dear colleague and friend was a speaker. And as a laboratory doctor, there are 2 points I want to highlight, the take-home message. One is the sample should be adequate and should be collected properly up to the mark where the tube is marked. That means proper mixing of the anticoagulant, and that sample should be there. And especially for surgeries, this may not be relevant for pediatric cases, but for surgeries, before surgeries, please don't just ask for PTI, ask for APTT. Very, very important. We generally tend to ignore APTT, simply go for a PTI. Please ask for APTT. Thank you. Thank you, Doctor.
Thank you.
Dr. Bilal, you mentioned about the hematocrit. Well, in most of the labs and in what is the hematocrit is not included as a part of it. Although it's very important if you want to have a near precision. Now, one of the problems which we face
डिनर के टाइम
selection of reagents. The reagents that are available, most of them, they are sensitive to the factor level of up to 20% or less. Now, the cases who are in between 23%, 30%, 35%, they are missing. Now, how to?
I think the best thing is that because nowadays there is automation and you have to use a quality control check. You have to do the ECAS, you have to do the internal quality checks, and your QC should be +2 -2 SD. It should be within that range. So you have to run daily controls and then calibrators and all those. So if quality control is within the limits and whatever, and the collection process is okay, everything is okay, there is no chance of pre-analytical error. So whatever result comes, I think that is you have to take that. So they are doing PTA, PTT right now, but manual or automation.
There is a protocol given how to select and which reagent to choose. You must go through this and you will have no problem.
So please share.
There is another unfortunate thing. There is, because the thing is that I should say that I had hoped that some people should.
And then amount of the sample of the blood. If it is 2 ml, it should be like up to 2 ml mark, and it should be always in vacutainer. And vacutainer should also be, they should be fresh. Sometimes they are, sometimes they are expired. They are lying months together, and then we start using them. The citrate will not be there. The appropriate amount of citrate, and your investigation reports will definitely be falsified. They will not be accurate. So that is very important. So thank you, chairpersons, and thank you, speaker. Now time for felicitations. So, Sister Harpreet, please.
We are really grateful for your insightful talk, sir. Now, I would like to request our chairpersons to felicitate the speaker, Dr. Sheikh Bilal, sir. Now, I would like to request Dr. S.S. Salathia and Dr. Sanjeev Kumar Digra to facilitate our chairpersons.
Now moving ahead with our next session, which focuses on challenges in management of hemophilia and value of emicizumab.
To chair this enlightening session, we would like to warmly invite on stage Dr. J.B. Singh, Assistant Professor, Department of Medicine, GMC, Jammu.
Yes, sir.
I encourage her to join some hospital recently, and got sufficient experience in the field of clinical hemology. And the last topic for this session is current challenges in management of hemophilia A and the value of prophylaxis with the emicizumab. I think wasting time out talk on this very important of current challenges in hemophilia and
Good afternoon, everyone. Thank you, JB sir, for the kind introduction, and definitely thank you, Sanjeev sir, for giving me this opportunity to be here in front of my teachers. So there are many challenges in the treatment of hemophilia. So we'll be discussing about them and definitely the value and the role of emicizumab in the current era. So where to point? So this is not working. Okay. So the slides are provided by the Roche, and these are the disclaimers. So apart from the challenges in the treatment part, the more important challenge is actually the patients, which the patients of hemophilia, they actually face. So the most common challenge is actually the psychological impacts of the disease on the patient's health. Right from the childhood, where there is a risk of intracranial hemorrhage, to the challenge of coping with the diagnosis and peer identity, and then progressing into adolescence with the challenges which adolescent feel is actually the adherence the management, and simultaneously the education of the adolescent group. Then going into the adulthood, they face challenging of managing these bleeds, and then simultaneously taking treatments and going to the work, managing their social lives, and then their reproductive decisions. And then by the time they reach the older age, the challenge of the joint arthropathy come, along with the various other comorbidities which the patients of hemophilia, they components, FFP and cryo, to the current era where we are now having the emicizumab like drugs, and now we are progressing towards the gene therapy. We have come a long way. So this already has been discussed that the treatment of hemophilia, the clotting factor concentrates, they can be divided into the standard and the extended half-life factor concentrates. So the standard concentrates were there, but what was the need of the extended half-life factors? So that definitely it is the longer half-life of the factor which is actually keeping the factor for the longer time in the blood, so actually reducing the frequency. So helping the patients, like the patients who were on the standard factors, they had to take it for a longer frequency, like 3 times a week, and with the help of extended half-life of the factor, it can be reduced to twice. And now the newer drugs, they are coming into existence, in which administration will be even once a week type of will be there. So another challenge which the patients of hemophilia actually have, that is the breakthrough bleeding. So why the breakthrough bleeding is occurring? It is because of the various peaks and the troughs of the concentration. So by the time there is a next scheduled dose is there, the patient has already reached a trough level. So that time the patient can have an increased risk of bleeding. So that is another challenge which the patients on the standard clotting factor concentrates or the extended, even the extended clotting factors, they are actually facing. So this is the vicious cycle of the joint damage which the patients of hemophilia have. So we know that first there will be a joint hemorrhage, then there will be damage to the joints because of the hemosiderin, then there will be lot of inflammation causing the hemoarthrosis, and then loss of cartilage and the narrowing of the joint space. So this is the vicious cycle because of the repeated target bleeds. So there came another challenge after these standard and the extended half-life factors which the patients receive is the inhibitor development, that is actually more and more worse than the disease itself, because these inhibitors are actually making even the moderate hemophilics the severe type, and the severe hemophilics with inhibitors, now the bleeding frequency of these patients actually increase. So as already discussed in the previous sessions, that 30% of the hemophilic patients, severe hemophilic patients, they develop inhibitors. So that is another challenge which the patients of hemophilia actually face. And especially there is a damage control theory for that. So whenever, especially the patients who actually get a lot of factors on demand, they have a higher and higher risk of developing the inhibitors. So apart from that, the child of hemophilia, what he faces in his life is a long-term risk of bleeding. Repeated joint bleeds can cause irreversible damage to the joints, causing chronic pain and arthropathy. There is a risk of intracranial hemorrhage, especially the children at less than 2 years of age, they are at an increased risk. And then the treatment burden, that is another wrench, that is the frequent need of the IV infusions, often leading to the use of the central venous access device insertion. So this was the study which was published in one of the, it was basically presented in one of the ASH meeting, in which they found that the total number of 146 patients of severe hemophilia, and they found that 58% of the patients had restricted physical activity, 51% of these patients had missed opportunities in the work, 58% social activity was cut off, and 55% of the patients felt frustrated. So the goals of the hemophilia treatments, they are now evolving. So there was a time when the focus was only on the treatment goal. There was only treatment goal, that is to prevent and treat the bleeding with the deficient clotting factor. But now the priority is on the prophylaxis. So prophylaxis is the standard of care for patients with hemophilia and for some people with moderate hemophilia. So episodic clotting factor replacement should not be considered a long-term option for these patients, as it does not alter the natural history of spontaneous bleed and related complications. And then the prophylaxis. So prophylaxis in hemophilia consists of regular administration of therapeutic products which are aimed at maintaining the hemostasis to prevent the bleeding. So because of all these challenges, there came a newer drug, that is imicizumab. So what actually imicizumab is doing, it is acting as a bridge between the factor 9A and factor 10, so helping in the formation of factor 10A. So it is actually mimicking the activated factor 8. So what imicizumab is doing, that there is some ease which are basically associated with the imicizumab. And one of the best thing is that imicizumab is to be given subcutaneously. It has a very long half-life, that is 30 days. It maintains steady state in plasma, providing sustained protection from the bleeds. And it is not expected to induce factor 8 inhibitors, which is actually crippling for the patients of hemophilia. And it is also approved in US for the routine prophylaxis for adults and pediatric patients in hemophilia A with or without inhibitors. And the dosing option is that after giving a loading dose of 3 mg per kg, it has to be given either 1.5 mg weekly maintenance or 3 mg fortnightly or 6 mg per kg once a month as a maintenance. So the clotting factor concentrates, they are typically used for hemophilia prophylaxis. However, because of their limited short half-life, they have to be given very frequently, and there is a very, very high risk of inhibitor formation. So only 40% of the patients using the standard or extended half-life factor 8 products, they experience zero bleeding episodes, and 30% of severe hemophilics, they develop inhibitors. So imicizumab is acting as a bridge to enhance the coagulation. It was launched in India in April 2019 as the first subcutaneous treatment options in patients with hemophilia with inhibitors. And basically the aim of that was to actually maintain a trough level of 1 to 3% and to reduce the bleeding to actually annual bleeding rate to 0%. And this was very well achieved in various trials associated with the imicizumab, which we will discuss later. Then apart from this, if we see the trials which has led to the approval of the imicizumab, there are many of these trials. So I will be discussing 4 of these trials, that is Heaven 1, Heaven 2, Heaven 3 and Heaven 4. In Heaven 1 and Heaven 2 studies, the inhibitor population was taken. In Heaven 3 and Heaven 4, in Heaven 3 no inhibitor patients were taken, and in Heaven 4 with inhibitors were there but in less number. So Heaven 2 population was on the pediatric population. The dosage was different. It is different, which was used in all the 4 trials of the imicizumab. So this is the pooled analysis from the Heavens program. So in the Heaven 1, the adult population, that is the adolescent more than 12 years of age with hemophilia with inhibitors were there, and the imicizumab was given in the dose of 1.5 mg per kg once weekly. Then in the Heavens 2, pediatric population with inhibitors, and the dosage was different, and 3 different dosages were given. In the Heavens 3 trial, without inhibitors, the adolescent population was there. And in Heaven 4, the both with or without inhibitors, but the dosage was 6 mg per kg once in a month. That was the dosage. So the main aims and objective of the study was to see the long-term efficacy and the safety of that is the emicizumab in patients with hemophilia. This was the pooled trial. So the primary endpoint was treated bleeds. So what was treated bleed was the patient who presented with the bleed, he was treated with the emicizumab, and then after emicizumab, whether the patient bled or not, that was treated bleed. If the patient is not having any bleed, so it was 0% treated bleed was there. So secondary endpoint, all bleeds, treated spontaneous bleeds, treated joint bleeds, and treated target joint bleeds was there. So safety endpoints, incidence of adverse effects, serious adverse effect, thromboembolic events. So one of the known complications of the emicizumab is the thromboembolic and thrombotic microangiopathy, although very rare, but still some of the cases they were also seen in the trials. And other analysis objectives were the percentage of participants with 0 treated bleeds, 0 to 3 treated bleeds, and proportion of resolved target joint bleeds, annualized infusion rate, and immunogenicity, that is the development of the antibodies. So there were different definitions which were basically given for all these terminologies in the studies. So basically it was seen, if we see the results, the treated bleeds, the annual bleeding rate, the treated bleed it was 1.4%, whereas the treated spontaneous bleeds 0.6 and joint bleeds 0.9. So it was seen that the patients, there was that the patients who had, so the study was basically every consecutive 24 weeks, the study was analyzed. So it was seen that in the first 24 weeks, the patients who had 0 bleed, they were 70.8% of the patients. So 1 to 3 bleed, 22.5%. And after first 24 weeks, there was a decline. There was decline in the rate of the bleeding. And we can see that the bleeding, the 80.2% of the patients had 0 bleeds after 24 weeks, first 24 weeks, and 17.9% of the patients, they had only 1 to 3 target bleeds. So it was seen that first 24 weeks, we can see that there was a decline. So there was a decline in the bleed, and then the bleeding, target bleed, annualized bleeding rate, that was maintained below 0% with emicizumab in every consecutive 24 weeks during the whole study. So it was seen that 95% of the patients had target joint resolution in during the study period. So coming to long-term safety of the drugs, out of the total 399 patients, the total number of participants with more than one adverse event were 95.5%. And total number of the patients who had a fatal outcome, they were only 0.3%. The serious adverse events were present in 23.3%, and the adverse event leading to the withdrawal of the treatment was only 1.3%. And local injection site reaction was quite high, it was 27.8%. The TMA-related event, especially in the patients who had concomitant, that is activated prothrombin complex concentrate along with the emicizumab, that was 3%. And other as well as the target joint resolution. So target joint resolution, they basically labeled after 52 weeks if the patient is having less than 2 weeks after 52 weeks of taking the emicizumab, then it was labeled as target joint resolution. So mean annualized bleeding rate decreased over the line with emicizumab prophylaxis, and the proportion of participants with 0 bleeds increased each emicizumab. Then the patients with the high annual bleeding rates, they are the population for the emicizumab prophylaxis, and definitely the people who are developing inhibitors because of the factor transfer rates. So they are the population. So this is overall improving the quality of life, reducing the healthcare burden, long-term cost savings, and increasing the productivity. So this is the warning which is given with the emicizumab, that is the risk of thrombotic microangiopathy and thromboembolism, which is, but actually it is less than 1% and it is more with the patients who are taking the other bypassing agents along with the emicizumab, that is the factor, that is novoserin factor 7, as well as the VIGA, that is also one of the drug. So this is actually a very interesting case. This is a real-time case, so I would like to present this. That this is a case which I actually faced in Naram hospital only. So this is a patient who came from Jammu only, and he had a history of bilateral upper and lower limb swelling, progressive ecchymotic patches, yellowing of eyes, and melena for the last 15 days. He was admitted in gastrosurgery department. He had a history of progressive weight loss. He was diagnosed with hypertension, and he was not on any treatment, no other significant past history. So on examination, vitals was stable, icterus was present, systemic examination was done. So this was the patient who had very deep ecchymotic, deep muscle, as the sir already told that the deep tissue hematomas, they are very well known of the clotting factor deficiencies. So he presented with this type of picture. So on investigations, on admission his hemoglobin was 5.3 grams. He had neutrophilic lymphocytosis. RFTs were normal. He had direct bilirubin was high. D-dimers were high. He was further evaluated, and it was found to have a periambulary mass, and it was suggestive of some mitotic pathology only. And for D-dimer height, the Doppler were also done. That was negative. So endoscopic biopsy was done, which revealed well differentiated adenocarcinoma. So it was a periambulary carcinoma, which was causing a surgical obstructive jaundice, and he was planned for a Whipple surgery. So a hematology referral was seen for low hemoglobin. So what we saw was low hemoglobin was definitely there with the history of melena, as well as there were deep hematomas, they were present with the background history of periambulary carcinoma. So we thought that it may be some Gaucher syndrome. So then the PT, as the sir already told, that PT was already done, but no, APT was not done. And we can also get the information on the velocity of clot formation as well as the acceleration of the clot formation. That can be basically, there are many parameters. The two parameters we took was the derivative 1 and the derivative 2. And the rotate, so what we did in our study, that we divided the patients, so this was a private hospital, so the patient burden of hemophilia is not very high. So some patients used to, basically from the Noida, the hospital had a tie-up with our hospital, and ma'am used to send the samples for hemophilia and Bethesda testing to our hospital. So we took the patients from that. So that time, what we did that we divided the patients, mild, moderate, severe hemophilia patients according to the one stage clot, and then we utilized rotate. So we did saw the study, and we found that there is one study who has also worked with rotate, and ABT got with one study, so many studies on ABT got and with phenotypic severity, but only one study on tech, no study on rotate with phenotypic severity of hemophilia. So what we did that time, that we took a paper Shima et al, and she had used one criteria for defining the severe phenotype. So we also utilized that criteria. So if that criteria was treatment periods, intrathecal hemorrhage less than 2 years, less than 1 year, joint pains less than 2 years, and 54 criteria were also there. We utilized that criteria. So in every trauma, one stage clotting essay as well as the phenotypic severity using that criteria was assigned. So we divided the patients into 4 groups: mild, moderate with non-severe phenotype, mild, moderate with severe phenotype, severe hemophilia without inhibitor, and severe hemophilia with inhibitor. So there were 4 groups, and we did both the tests. So with ABDT clot waveform analysis, we got the inference that we could not separate inhibitors and without inhibitors. With ABDT clot waveform, but we could find that the patients who were mild, moderate but severe phenotype, they behaved similar to the patients who had severe hemophilia without inhibitors. So this was the part of interpretation we got from our study. But we wrote them as that graph of last that first case is mild, moderate, non-severe phenotype. Then second case in which
Thank you, bye.